And everyone in the waiting rooms should wear face masks. In urban areas due to smartphones with excellent cameras. A strong visual component of dermatology makes dermatology very useful, like radiology. So visual component is very high. Teledermatology can also be used for follow-up after a first face-to-face consultation. Several studies have shown that teledermatology diagnosis to be accurate with very high sensitivity and specificity. Implementing precautionary measures. So the conclusion of my talk, implementing precautionary measures now in hospitals and clinics will help prevent the spread of COVID-19 and other pandemics in the future. Teledermatology, if properly done, can be a safe way to practice dermatology. It will save a lot of time and energy for both patients and doctors. Thank you. That's all.
Thank you so much, sir. May I now request our organizing chairman, Dr. Sabina, to give away the certificate and bouquet to Dr. Govinda Pokhar. Now we move on to our next session, the neglected skin diseases. The first speaker is Dr. M. Ramam. He is the professor at AIIMS New Delhi, and he has got many publications in national and international journals, and he's the chief editor of IGJVL from 2014 to 2017. So let's welcome Dr. M. Ramam. Over to you, sir.
Thank you. for your warm welcome. It's a pleasure to be at this conference, SODVELONCON. I wish it had been in person, but I think with the world the way it is, we might have to wait a little bit before that will happen. But it is indeed a pleasure and a privilege to be with you this afternoon. Let me begin sharing my screen. Can you see my screen?
Yes, sir.
Oh, good. Fine. Thanks for that feedback. Yeah, things are a little different when we are doing it virtually. So I appreciate that. So now cutaneous tuberculosis continues to be a problem in many parts of the world and particularly in ours. And so this is not a disease that we should neglect, which is why I removed a neglected entity from the title slide. Most cases fall in the category of secondary tuberculosis, and other variants are rare. When we analyzed the patients that we were seeing in our department, we found that lupus vulgaris and scrophaloderma were the commonest. We were seeing some of the other varieties, but less than these two. Let's take a look at the clinical presentation, which is what most of us will be faced with in the clinic. Now, this is the classical appearance of lupus vulgaris with an active edge trailed by scarring. On the face here, again, we have the same appearance, but here it is biting the nose in a manner that gave it its name of lupus, which means wolf, and wolves we know bite. In the subcontinent, many lesions of lupus vulgaris occur on the buttocks or on the surrounding skin, and this is something that we recognize as a fairly common manifestation of cutaneous tuberculosis. In fact, when we analyzed the site distribution of cutaneous tuberculosis in our patients, we found that about 40% of them had it below the waist, whereas in other parts of the world, the head and neck is the commonest site for cutaneous tuberculosis. Now, these translucent papules on the periphery, when you do dioscopy, you should see a deep golden brown color. These are what are referred to as apple jelly nodules, and there's a very close association in the minds of dermatology residents and even medical students who have to give MCQ exams between apple jelly nodules and lupus vulgaris. But in reality, these are often obscured by hyperkeratosis and scaling, which is very common in lupus. Lupus vulgaris can be quite small, or it can be massive, involving nearly half the anterior abdominal wall here. It's usually confined to one anatomic area, but sometimes, like in this patient who has it both in the hand and the groin, you can have more than one area affected. This is a rare presentation. I remember that when this patient was brought to me with this mucocutaneous lesion, I was very skeptical of the diagnosis. But a few months later, the same patient was brought to me after treatment, and it is clear that he has improved significantly with anti-tubercular treatment. And this is a theme that I will return to during the rest of the presentation about how the treatment can sometimes help to establish the diagnosis. Palatal lesions are also rare and can lead to perforations. Symmetrical plaques on both legs are uncommon, and so is BCG lupus. But I think as dermatologists working in communities where tuberculosis is common, we should be aware of these rare variants also. Tuberculosis verrucosa cutis is another variant, and this presents as a keratotic plaque, usually occurring on the acral skin. And in some patients, the hyperkeratosis may be very marked. Keratotic lesions can occur in other areas apart from the acral skin. So it's not just the site that seems to determine whether the lesion is verrucous or not, but also the host response. Scrofuloderma is a variant of cutaneous tuberculosis that occurs by the extension of tuberculosis to the skin from underlying structures. And that structure is usually the lymph node, as in this patient with lymph node on the neck. Sometimes multiple lymph node groups may be involved, and this is common in children, especially malnourished children. It's not generally recognized that lymph node scarring is a sequelae of scrofuloderma, and that can lead to lymphedema, which has occurred on the genitalia here, because both groups of inguinal lymph nodes were scarred by tuberculosis, and that compromised the lymphatic drainage of the genitalia. And this is a patient in whom the leg is swollen because of tubercular lymphedema. When you treat these patients with anti-tubercular drugs, the skin lesions improve, but the lymphedema is because of fibrosis, and that improves only partially or not at all. Now, we said that scrofuloderma most commonly occurs overlying a lymph node, but sometimes it can also follow bone tuberculosis, as it does in this patient who had tuberculosis of the wrist and metacarpal bones. When the focus is in the subcutis, some people refer to these lesions as gammas, but to me, it appears that there's very hardly any difference between a tubercular gamma and scrofuloderma. Here is another example of tubercular gamma, very extensive in this case. Now, this is a patient who has scrofuloderma, but the underlying lymph node swelling is very large and cystic, what is sometimes referred to as a cold abscess. And occasionally, there will be a patient who will present only with a cold abscess without rupture onto the overlying skin. The same process of subcutaneous involvement going on to the skin with scarring can occur on the breast. Some people call it tubercular mastitis in this site. And interestingly, sometimes you can have a combination of lupus vulgaris on the nose and healed scrofuloderma of the preauricular lymph nodes. Here is another example where you have lupus vulgaris and scrofuloderma. This is a rare manifestation. This is a man who had intestinal tuberculosis and then seeded the tuberculous bacillus around his anal area, and he developed orificial tuberculosis. Due to disseminated BCG infection in a child who had severe combined immunodeficiencies, basically no functional T cells. Now, 1/3 of all patients with HIV have tuberculosis, and 20% of deaths in HIV are due to TB. But when it comes to cutaneous tuberculosis, our experience has not been, particularly showing that they are different, but in UP, they found that the clinical findings and the systemic involvement appeared to be worse in the group of patients who had HIV, though the treatment response was unaltered. But for us, cutaneous TB is not a marker for HIV infection. So if somebody presents with cutaneous tuberculosis, we don't order an HIV test, because when we did it in a group of patients, our colleagues in Safdarjung Hospital, Dr. Ramesh's team, and we both independently did this in about a total of about 70 patients, and none of them were HIV positive. So it's not a routine test for us. Tuberculides represent a cutaneous hypersensitivity response to tuberculosis occurring elsewhere. And lichen scrofulozorum is an example where you have small grouped crusted papules predominantly on the trunk, and papillonecrotic tuberculides may occur with central crusting or scarring. Erythema induratum presents as indurated nodules on the calves. And I feel that erythema nodosum should also be considered a tuberculid in areas that are endemic for tuberculosis. The clinical features are, of course, identical to those due to other causes, so you have to be sure that the erythema nodosum is indeed due to TB in your patient. But it has to be kept in mind. Penile tuberculosis have a very distinctive appearance of recurrent and remittent small ulcers on the glands which heal with scarring. And when we see this appearance, we go ahead and investigate for focus of tuberculosis. Varicose tuberculosis are an uncommon variant, and so also as this patient who had tuberculosis confined exclusively to both his axillae and nowhere else. Sometimes finding the systemic focus of tuberculosis is easy, as in this patient who had clinically obvious tuberculosis of the lymph node. You can see that the lymph nodes are swollen in his groin. But in other patients, chest x-rays, ultrasound of the abdomen, and other investigations may be required. We were able to demonstrate a focus in about 3/4 of our patients, which means in about 25% of the patients, we have gone ahead and treated them on clinical grounds alone. How do we establish the diagnosis of tuberculosis in patients with skin TB? Biopsy shows granulomas in about 80 to 90% of cases. In our database, it was 90%. But we know that this is not sufficient. You need more than just finding granulomas. So we looked at the data in our path department, and we found that 1/4 of the patients do not show granulomas, and in about the 3/4 who did show a granuloma, a lichenoid granulomatous diagnosis, and I'll show it to you. And there were other granuloma patterns also. Here, if you see these, then you need other information. But if you see a lichenoid granulomatous pattern, then you can suspect that you're looking at cutaneous tuberculosis on the biopsy. And this is the lichenoid granulomatous pattern where you have a band-like infiltrate containing granulomas, basal cell damage, and a deep nodular infiltrate. The second pattern of histopathology in cutaneous tuberculosis is a diffuse infiltrate containing both neutrophils and granulomas, as seen in this biopsy. How about the Bantu test? It was kind of moderately helpful if you look at this data, but we asked ourselves, can it help when the diagnosis is in doubt? And we analyzed patients in whom the final diagnosis was TB, and another group of patients in whom we were sure it was not TB. There were some that were difficult to classify even after further investigations, so we confined ourselves only to these two. And we found a lot of overlap in the Bantu positivity between these two groups. And when we do an ROC curve, we found an area under the curve of about 65%, indicating that the test was not particularly useful. So this is what we have always suspected.
Recording stopped.
That the Bantu test did not contribute much to the diagnosis.
Recording in progress.
Visible lesions at the Bantu test occurred in patients who truly had tuberculosis, and we call this Bantu plus. So if you get vesicles or papules at the Bantu site, then it's more likely that the patient truly has disease and not just infection. And that's the problem with the interferon gamma release assays also, which are now becoming more popular. Now, this first advantage doesn't really apply to our countries where people are given BCG in the first year of life, because that fades away, the tuberculin positivity to the BCG. But also remember that these assays test only for infection and not for disease. So it doesn't have much value in communities where nearly 40% of the general population has infection. But cutaneous tuberculosis is an infection. What about microbiological diagnosis? Well, it's paucibacillary, and that creates problems. You can't see the bacillus in the tissue. Cultures have low sensitivity. And so that sets the stage for the polymerase chain reaction. And I remember being very excited when this became available. But we are now, found in 3 different studies looking at 2 different targets that these results are not good enough to permit clinical use. We also studied mRNA PCR and did not find that useful. And recently our colleagues in Safdarjung Hospital, this is a fresh paper, 2021, they looked at GeneXpert MTBRIF, which is now freely available, quite commonly available in most national tuberculosis programs. And they took 47 patients, all of whom responded to ATT, and only 7% of them were positive by GeneXpert. So it seems that our search for a good laboratory test for cutaneous tuberculosis will still continue. This is the recommended treatment for new cases of tuberculosis. And a response to treatment, as I mentioned earlier, is very gratifying evidence of the diagnosis. Now, so we looked at the treatment response and we found that most patients who respond do so within 35 days. They don't get better. This is after 10 days, this is after 4 weeks, and this is after 6 weeks, but enough for a dermatologist to know, and even the patient, that they are better. Now, the idea of using a treatment as a test of diagnosis is not new, but what we are saying is that if in 6 weeks the patient is not better, then please think again. Is it truly tuberculosis or not? Don't keep giving treatment for 1 year, 6 months in order to find out. Now, at this point, I'm usually asked, what about the non-responders? Could they not be having drug-resistant tuberculosis? And certainly this is possible. There are now many reports of drug resistance in tuberculosis. But when we analyze the reason for treatment failure in some patients, out of 24, nearly half were because of a wrong diagnosis. So this reflects belief that somebody who we think has tuberculosis is not responding to treatment, therefore it must be drug-resistant tuberculosis, may not be right, and we should be careful before we label somebody as drug-resistant tuberculosis and start giving him second-line treatment. That brings me to the end of my presentation, and I would like to acknowledge the help of many colleagues over the years who have contributed to this work on cutaneous tuberculosis, both within my department here in the left column and from other departments like microbiology, biotechnology, pathology, and my good friend Dr. Ramesh in the department at Safdarjung Hospital. Thank you very much for your attention. I'm happy to take any questions if somebody has.
Thank you so much, sir, for enlightening us with your knowledge on cutaneous tuberculosis. Once again, very much thank you, sir. If you have time, we'll definitely take some questions. Now we move on to our next speaker. Our next speaker is Medical Director at the Leprosy Mission Nepal, Anandaban Hospital, and he has a number of publications in national and international journals as well. And he was awarded by the Nepal Health Research Council as Senior Researcher of 2016. Please welcome Dr. Mahesh Shah.
Hello. Can you listen to me?
Yes, sir. We can hear you, sir.
Yeah. I'm Dr. Mahesh Shah, and for me it is a great privilege to give this presentation on this occasion. And Babu, just slide change. Slide change. Yeah, but I am working at Anandban Hospital. This you can see. This is one of the a jungle area where Anandban Hospital. It is one of the oldest hospital in Nepal, working with mainly with leprosy, and we have 110 total beds. Out of them, 20 it is for the leprosy patient, and 30 for the general patients. So that area, there is no any other bigger hospital. So we look after the local patient on that area, and we have expertise on dermatology, orthopedics, which is needed for the leprosy reconstructive surgery, and also we are developing other faculties, and we have very good lab for the leprosy diagnosis and research in Nepal. So this is my outline of the talk on this occasion. So I'll be talking briefly about the introduction, global leprosy situation, national leprosy situations, and clinical presentation at the time of diagnosis, relapse, and WHO surveillance of drug resistant and impact of COVID-19 on leprosy services. So leprosy, we say it is one of the neglected tropical disease, but which can occur at any age. These are the patients which I have diagnosed. Younger patient, it is 2 years, 4 months child to 95 years male, and here 2 and 4 years child as mother has borderline lepromatous leprosy, and so that child in early stage he got few hypopigmented skin lesion, and we did the biopsy, smear and biopsy, and we confirm it is leprosy. So it is, and another we can see that 95 years male who has been treated for the joint pain several years, for the rheumatic arthritis, and lastly he developed ENL and was diagnosed leprosy at the 95 years of age. So we can say that it can occur at any age group, but predominantly we see that younger people around, we can say that 30 to 35 years of age, those people we diagnosed many patients pick, and they are, we can say that they are very active young people who can contribute in the community, family, and they can earn the for the family, but unfortunately they develop leprosy. And leprosy, it is a very unique bacterial disease which lastly may lead to deformities, and we can see that in leprosy it is mainly deformities in the face, so it is maybe the nasal collapse, larynx, maybe the upper extremities, that we can say that wrist drop, clawing of finger, and in the foot also there will be the foot drop, clawing of toes, and those, if it is anesthetic, so there is chance of recurrence ulcer, then they can sometimes, if it is very badly infected, they have to lose their hands or feet, and so that makes the difficulties in their daily life, and they are, we can say that they have to be helped by the other family member in the family for his daily life. Globally, that we can say that every year more than 200,000 cases are detected, but due to, we can say that it is the trend, WHO that just recently came for the 2020, so it was, we can say that rapidly decreased new cases, and also we can say that child cases, it is only not, we can say that disease has decreased dramatically. No, it is the impact of, we can say that especially COVID-19, people are not able to, and also if we see the WHO report that in 2019, 160 country had reported, but this year only 127 countries are able to report the WHO data. So on that way, that we say that all the figures which can see that indicators, prevalence rate, new detection rate, child rate, and also disability grade 2 at the time of diagnosis, all are decreased. In Nepal, we have in 2020, we have new cases detected. It is only 2,304 cases. Total new child cases are 142. Among them, we can say that grade 2 disability among the new cases, it is 101, and grade 2 disability among the new child cases, it is 6, and female, we can see that among the new cases, it is 918. So more multibacillary cases we see in the new cases, especially we can say that in the adult, it is more multibacillary cases, and in the child, it is more paucibacillary cases. We say that leprosy, we say use with hypopigmented or erythematosus. We teach all the, we can say, public and everywhere. But nowadays we see that we have lots of specialty, and sometimes leprosy skin lesions are asymptomatic, and the presentation may be different. And nowadays we see that around at Anandman data, we see that around 50% cases, they are diagnosed first time, maybe type 2 reaction or type 1 reaction. And this picture, we can say that the patient has fever, multiple nodules, lymph node enlarged, and so they were very easily first, if they go to the bigger hospital, where the specialty, they will be treated as septicemia or like that one. But lastly, sometimes they are diagnosed leprosy because not presentation it is different. Then also sometimes we see that they have got the not pain only, and there is no skin lesion. So people goes to the neurologist, and they have all the investigation done from the neurological point of view, and sometimes they do the nerve decompression for the maybe the ulnar or median nerve, and lastly when they develop the skin lesion, then only they are referred to the dermatologist. So these are the nowadays with presentation we see. And however, we can say that leprosy, one of the key issue we say that transmission leprosy, have to stop the transmission, but indicator of the transmission, it is the child proportion. But recently I have visited one of the community where in the pocket we can see mother, he has leprosy, and all three child has leprosy, and this child with the facial skin lesion, type 1 reaction and type reaction and neuritis. So it is already we can say the deformity is already there at the time of diagnosis. So again, we should always request, encourage to the patient that they have to bring their family, or because in Nepal we have the passive case detection, so rarely we go to the committee if we find. So it is one of the now coming of the issues that we have to encourage the case detection. Then we have to go to house, or at least we have to do active contact examination. Relapse in leprosy, it is around globally, we say that around 1%. In the 2020, there were 2,990 cases were relapsed. Among them, Nepal has reported 19 cases. In the 2019, Nepal has reported 36 cases, but due to the COVID effect, we can say that there are less patients are able to come to the Anandban. And in Nepal, Anandban it is the, we can say that confirmatory center for the relapse, and where we, if the untreated leprosy patient, we do CT skin smear, and we see the morphology, we do the mouse foot culture, and also we take the sample for the PCR. But we have in our setup so far there is no PCR sequencing, so we have to send abroad for that. So there was a, we can say that a large, one of the prospective study, it was done in the antimicrobial drug resistance, and it is that it was a 7 years project, 2009 to 2015. So there were 1,930 cases detected. Among them, there were relapse and also new cases. So result of that, it was for the 78 cases, rifampicin resistant has been detected. 87, it is dapsone resistant, and 21 cases ofloxacin resistant. We know that dapsone resistant, it is already approved in 1960, but still because we are keeping it, and we give that one in the combination. And rifampicin, it is the main powerful drug of the multi-drug therapy, but now there is that emergence of rifampicin resistant also. And the second line drug we have in combination, it is one of the ofloxacin, but it is very commonly used in another condition, so there is already resistant to that one. Regarding the clofazimine testing, it is not so far done in the PCR method, but it can be done in the mouse foot pad study only. But only one lab in India carried it to that one, but in our lab so far we are not doing. So anyhow, rifampicin, clofazimine resistant, it is a not reported, and but acceptance, it is sometimes difficult to convince the patient. And we can see that relapse sometimes maybe the presentation is like, it looks like some continuous, some like that one. Yeah. So now we have to reduce the burden of leprosy, that and give the quality service. So there is a roadmap from 2020 to 2030, and there are several indicators that it is shown in the 2020. It is already, we can say that we have started, but I'll talk a little bit about the impact of COVID-19 leprosy services. So surely that nucleus diagnosis has been reduced because lockdown was there, people are not, and so health services were also shifted to the care of the leprosy patient, and so people who are not able to reach the nearby health post or hospital, and also there was staff who were looking for the leprosy, they were posted to other services, and there was no active case detection by done in the pandemic situation, and relapse cases are also they were not able to attend the clinic. And treatment, some of the patients, we encourage them to go to the nearby center, but there was also deficit of medicine in some of the centers, so some of the patients were not able to get the multi-drug therapy on time, but similarly, the reaction management was at Anandman or referral center was open for the leprosy patient, but maybe in the periphery it was maybe temporarily not properly managed. So there is a risk that will increase the disability. Just I would like to share that even during the lockdown, one of the patients from Rukum, he came the ambulance, very expensive treatment because it takes 2 days journey and he has to pay high charge for that one, for the type 1 reaction. This is the patient who has got the type 2 reaction, and also she developed COVID. She was getting the prednisone, but outcome was not much complicated, and so she. So our experience that regarding the COVID in the leprosy patient at Anandban, where in our lab we modified for the PCR service for the leprosy in the hospital. So we tested for the local community and also for the leprosy patients. So there were 54 cases where leprosy patients who came for the services. Among them, 54 were positive for the COVID, and among them, 20 patients were taking prednisone. 15 was taking prednisone for VNR, and 4 cases for type 1 neuritis, and 1 patient with depth and hypersensitivity. So all of them patient, we can say they were admitted, and Anandban, we have got the isolation ward and we treated them. Among them, there were 2 deaths. One was old man who has got the previously asthma, other complications, so he died, and another young man, middle-aged man, who was taking MBT and also prednisone for the neuritis, but he died with the complication of COVID. So most outcome, it was, although we were very worried that our leprosy patients were getting the immunosuppressive drug, prednisone or thalidomide, that maybe the complication may be very, very high, but we find that in our experience that they recovered well. Most of them were mild to moderate, but for the severe we haven't facility, but no any leprosy patient gets severe problem. Thank you very much. Is there any question or suggestion to me? Thank you.
Thank you so much, sir, on highlighting on leprosy statistics of Nepal, and definitely resistance cases, and definitely the difficulty in treating patients during COVID-19 pandemic. Before we move on to our next speaker, we'll be sharing one contact information for entertaining your questions. We have shared one WhatsApp number. You can WhatsApp us your queries, your questions in this WhatsApp number. Please note it down. One second. Can you project that information? Please kindly note down your WhatsApp number that we've provided, and you can WhatsApp your questions, your queries, and then we can enter in the questions in the at the last. So now we move on to our next speaker. We move on to our next speaker. He's the professor, Department of Dermatology at Bankura Samilani Medical College. He has got many publications in national journals, around 19, and 55 in international journals. He has received many academic achievements. To name a few among many, it is B.B. Gokhale Medal Award, Dr. Badri Narayan Prasad Research Award, L.N. Sinha Award, Salil Kumar Panja Award, etc. So let's welcome Dr. Nilay Das, and he will be talking on PKDL. Is it a threat to achieve Kala Azar elimination? Over to you, sir.
Thank you, ma'am, for the kind introduction. Good afternoon, delegates. We all know that PKDL is the cutaneous sequel of Kala Azar or visceral leishmaniasis. For the next 15 minutes, we shall discuss its importance with regard to Kala Azar elimination. Ladies and gentlemen, our understanding of PKDL is almost 100 years old. Since the time Dr. U.N. Brahmachari recognized this as a separate clinical entity and named it as dermal leishmanoid. 5 years later, Drs. Acton and Napier renamed it as PKDL, the name we know it today. Since then, it has been mostly of academic interest and neglected, of course, in terms of healthcare policies and priorities. It was in 1992 when this article made the world to think otherwise. In 1980, there was a Kala Azar outbreak in South 24 Parganas in India. After almost being non-existent in the region for 2 to 3 decades, this could not be explained by population migration from endemic areas. However, there was one person, the picture you can see out here, who had suffered visceral leishmaniasis 30 years ago and developed PKDL about in 1980s, and then he developed PKDL in 1976. Entomological investigation confirmed that sandflies acquired the infective potential after biting his nodular lesions. Understandably, the world had recognized the infective potential of PKDL after this report. And in 2005, WHO came up with the regional strategic framework to eliminate Kala Azar by 2012 in Southeast Asia, which of course we are yet to achieve. But this was the time when PKDL was recognized as a threat to achieve the target of reducing Kala Azar to less than 1 per 10,000 in a sub-district level. In the same year, a memorandum of understanding was signed between India and Nepal and Bangladesh to achieve this target by 2015, which was later extended to 2017, and later Bhutan and Thailand were also included in the move. Now, let's take a look where we stand. Kala Azar that you can see in brown has got 3 eco-epidemiological hotspots: the Indian subcontinent, East Africa, and Brazil.
Leishmaniasis is a group of vector-borne diseases. These are the most neglected diseases worldwide.
But PKDL is localized to only 3 geographical pockets. And we can see that, unfortunately, Nepal has also found its place in the list. Interestingly, another important fact about PKDL that we can witness in this line diagram, where there is a decline in the VL load from 2014 onward. But PKDL cases started rising, reflecting the fact that PKDL echoes the VL surge earlier in 2007, that you can see, and 2011. This phenomena is due to the lag period in developing PKDL after a person suffers visceral leishmaniasis. This phenomena has been documented in neighboring country, Bangladesh. Thus, the take-home message is to keep a vigil on rising incidence of PKDL cases after every upsurge of VL in that locality. Though there can be a lag period which can extend from 3 years to 7 years or more. In India, too, we have noted a similar lag period, but there was another factor playing its role: active surveillance. Active surveillance was started in West Bengal in India in 2013. The active surveillance, apart from picking up the hidden cases, taught us a few more things. The macular lesions are not uncommon as found in passive surveillance, rather more prevalent than papular and nodular one. Since they cause less deformity, they are less reported.
Transmission,
It was noted that PKDL is not a male-dominated disease as one thought of. But the females hide their disease unless the lesions are on the face. I think there are some background disturbances. Can you just switch off the mic? Thank you so much. And this phenomena that people hiding the lesion can be appreciated in this lady who presented to us only when she developed hypopigmented macules on face. But more characteristic are symmetrically distributed lesions which are mostly on the trunk, and that's why underreported since they're hidden by clothing. And one very important thing about PKDL is that it is likely to be confused with, of course, leptomatous leprosy that we have just heard. We can appreciate the numerous hypopigmented macules on trunk and buttocks and limbs. PKDL and leprosy being both prevalent in the same geographical area, differentiating them is of extreme importance. Testing for sensation and of peripheral nerves for thickening and tenderness can give and never should be missed. On the face, they tend to occur around the muzzle area that we can appreciate in this point. And here too, where few of the hypopigmented patches around mouth have become infiltrated. Apart from macules, the papules also tend to occur in the similar distribution. And this is one subtle differentiating point from lepromatous leprosy, where involvement tends to occur more on the ears. Not only macules and patches, PKDL patients can present with plaque and nodule too, which can involve the extremities, even the dots of the hand, and even palms. One thing to remember over here is that involvement of hand, feet, genitalia, and tongue suggests severe disease. Papules and nodules can be widespread, and it requires high index of suspicion to diagnose PKDL. and biopsy always helps us when there is a doubt. Another interesting fact about PKDL is that involvement of axilla. If you note closely, you would notice that the fault of axilla is free and the involvement is on the axillary folds. The same thing can be appreciated in the groins. Fault of the groin is free, and here is a diffuse involvement of the thighs with hyperpigmented patches. We can appreciate the involvement of genitalia too over here. And in this patient, the involvement of genitalia is more prominent, and as I had previously described, it suggests a more severe disease. Coming to another interesting fact about PKDL, at times you would be able to appreciate the photosensitivity, and this can be a telltale sign for diagnosing PKDL. Photosensitivity can be appreciated in this young man too. Nodules and papules around the muzzle area with photosensitivity, think of PKDL. Another severe form of the disease evident by the infiltration of the tongue that we can see over here. Papules and plugs over feet suggest severe manifestation. And you can appreciate the spontaneous ulceration over here too, which is more evident in this gentleman. It is essential to highlight that spontaneous ulceration is a clue to a severe form of disease. Thus, we get to know that there will be time when clinical diagnosis won't be sufficient and there will be differentials which need to be differentiated, and we need to exclude them by doing some investigations. The diagnosis rests on three pillars. First, of course, is demonstration of parasite, either by slit skin smear, histology, immunohistochemistry, but they are not sensitive enough. Thus, we look for detecting antibodies. And RK39 strip test has revolutionized the diagnosis in the field. But of course, the specificity is lacking. The most sensitive to detect the parasite is to detect the DNA by using PCR. But of course, its use is limited by the infrastructural requirement and may be required to diagnose difficult to diagnose cases. We in our lab have been using the ITS-1 PCR. Taking a look at the slit skin smear, it is limited by their low sensitivity of around say 58% and difficult to perform in the field situation. Whereas the RK39 has got high sensitivity to around say 94 to 100% as well as high specificity of 93 to 100%. But we need to remember that RK39 may also show some false negative and false positive results in some situations when we need to do PCR, which we need in few of our patients, which we had reported. Histopathology is invaluable for diagnosing PKDL. Instead of what it was thought in earlier days, we don't find granulomas in PKDL, but infiltrate of lymphocytes, macrophages, plasma cells, the intensity of which depends on the type of lesions. For example, in the macular lesions that we can see over here, the infiltrate is mostly perivascular and periappendigeal. Whereas in nodular lesions, there is immense infiltrate in the dermis with a thin grain zone beneath the atrophic epidermis. In some cases, we may be lucky enough to find LT bodies in histopathology too. Coming to the main focus of gall ulcer elimination, it rests on the management of the reservoir, that is post-gall ulcer dermal leishmaniasis. There are hiccup areas in this management. The first being, we don't know what should be the exact duration of therapy. whether it is to be continued till complete resolution of the lesion, or we can stop it after a fixed duration. Resistance to drug is another key issue. And we don't find response to antimonials nowadays. And even there are relapses after treating them with miltefosine. We have to remember that active search is extremely important to eliminate the disease, since healthcare seeking behavior is poor in this condition. Control of the vector, the sandfly, can never be undermined and is equally important to stop the transmission chain. There are various drugs to treat the condition, which includes antimonials, which has been the cornerstone for treatment for ages, given at the dose of 20 milligram per kg per dose, but not exceeding 850 milligram. But the problem is with the availability nowadays, and furthermore, it cannot be given on an ambulatory basis. Miltefosine, which is the standard of care at present, with a dose of 100 milligram per day for those weighing more than 25 kilograms and 50 for those who are weighing less than that. The prime side effect being gastric irritation, nausea, and vomiting, which we have found in the cohort of cases which we have followed, and these need supportive therapy and some counseling, then the patient will be able to continue with it. Amphotericin B, which is going to play a pivotal role. The deoxycolate has got so much of side effects when we have treated them with deoxycolate. Thus, the present recommendation is to use liposomal amphotericin B. The problem is with rising this mucormycosis, the availability of liposomal amphotericin B has become a concern. It is given at a dose of 5 milligram per kg twice a week for a total of 30 milligram per kg. Thus, 6 doses are required. And of course, we have got newer agents coming up like paramomycin and immunotherapy. Treatment guidelines of PKDL also differs in different regions. For example, in East Africa, antimonials and liposomal amphotericin B are the recommended drug. Whereas in our part of the world, the guidelines still relies on conventional amphotericin B, and we have got miltefosine in our hand. Thus, to conclude, we have to eliminate PKDL if we need to achieve the target of eliminating Kala cell, for which active surveillance is extremely important, and we have to focus on vector control too to achieve this elimination. We are privileged to work in an institution where Dr. Ronald Ross discovered the culprit behind malaria. I would like to thank the organizers, Aparna ma'am, Dr. Sabina, for giving me the opportunity to share my experiences on PKDL with you. Thank you, everybody.
Thank you so much, Dr. Das. Thank you so much for extending our mental horizon on the diagnosis and treatment of PKDL. Now we move on to our next speaker, but before that, we are again sharing the contact information. Queries and questions, and we'll be entertaining those questions at the end of the session. So now we move on to our next speaker. She is Associate Professor of Pathology at Nepalganj Medical College and Teaching Hospital. She has got many publications in national journals and many publications in international journals as well. Please welcome Dr. Pragya Gautam.
Good afternoon, delegates. Am I audible?
Yes, ma'am.
For inviting me as a speaker today. I reside in a western zone of Nepal. My workplace is Nepalganj Medical College, and I'm working here since more than a decade. So here I would just present my work, what I've been doing here, and in a research format. So I talk about the topic, is cutaneous leishmaniasis endemic in Nepal? So since I have been working here, leishmaniasis has been coming now and then. So this leishmaniasis is the world's most neglected disease, and its diagnosis is an arduous topic. So this leishmaniasis, these are a group of vector-borne diseases, as we all know, so caused by a leishmanian protozoan parasite and transmitted by the infected female phlebotomin sandflies. And the average incubation just 2 to 6 months. We all know that. So now, and we should know that the transmission is anthropogenic and human-to-human transmission by the vector without other animals involved in between. So this Nepal, our country Nepal, where the rural areas are at less than 600 meters above sea level, this favors the transmission of the parasite. So the risk of transmissions are heavy annual rainfall, mean humidity above 70%, maximum temperatures of 38 degrees centigrade, and a minimum temperatures of 15 degrees centigrade with a variation less than 7 degrees centigrade. And there's abundant vegetation, subsoil area, clay soil, all these favor the transmission of this parasite. So we know Nepal is a country of geographic diversity with fertile plains, subalpine forests, hills, and 8 of the world's 10 tallest mountains, including Mount Everest. So this altitudinal belt and the climatic change, like the elevations ranging from less than 100 meters to more than 8,000 meters, and the rainfall from 6 inch to 16 feet, the country has uninterrupted snowfalls and climatic changes. This may be the favorable situation for transmission of this parasite. So it has become a major public health problem in Nepal. When the first case was diagnosed in 1960s, and we are now said to be eliminating Kala-Azar, still we have cases coming to us now and then. So 12 districts of central and eastern Tarai region of VL are supposed to be endemic in our 2019 Kala-Azar guideline in Nepal. However, 6 new districts added in 2016, including the hilly districts like Kathmandu and around, and 23 districts are said to be endemic, whereas 48 districts are doubtful endemic, and 6 districts are non-endemic. So this is just talking about visceral leishmaniasis. So it's a very sad story that cutaneous leishmaniasis has not been documented, or very few cases documented and proved in the Nepali diaspora. So So now the scheduled elimination was like 2020, but we just say that disease is eliminated if we see less than 1 case in 10,000 cases. So I think the elimination is to be postponed because we are seeing cases every week out here in this western part of Nepal, where the cases are coming from the hills. So we know the life cycle, like the infected sandfly bites a host, and then the mastigotes proliferate, and the macrophages take into action, and there is a granulomatous reaction and ulceration along with pyogenic infection. So when we see this life cycle, at each stages we get a different clinical picture, like from a nodule to papule to ulceration, and even secondary infection, pyogenic infection. So now, yesterday just I was in WHO, Nepal government and FEDREC meeting in Kathmandu, and we came to know a very interesting story that the vector Argentipus for VL has been changed to Phlebotomus neglectus and Phlebotomus longitudinus. So this is another threat to us for eliminating this leishmaniasis in Nepal. So forms like visceral, cutaneous, and mucocutaneous. Among these 3, we know that the CL is the most common form, more than 50%. So in Nepal, the CL is the most neglected. Please mute your mics. So this among the three clinical forms, cutaneous, mucocutaneous, and this visceral form, this cutaneous form is supposed to be the most common worldwide. And so in Nepal, it's underreported. I feel this is underreported. And our Nilesh sir also talked about post-Kalazar, which was a sequelae of VL.
Good morning, everyone.
It has been reported in the eastern region of Nepal from BPKIHS. And now focusing on this cutaneous leishmaniasis, as I already told that it's the most common reported per year. And it has been, the presentation of this disease has been changed from old world to new world. So it has a heterogeneous presentation. And we now come to know from the other studies that 30 proven species are causing cutaneous leishmaniasis, with more than 40 additional species probably involved. And if this, more serious type is the mucocutaneous form, which affects the mucous lining of nose, mouth, and throat. So this leads to disfigurement, and it does not heal spontaneously. And it depends on the species, they can develop visceral leishmaniasis. So our differential diagnosis is varied, and because it has a heterogeneous presentation, the patients come from various departments. Like, and if the patient goes to surgery, they come with cutaneous malignancies, the infected epidermal cyst, traumatic ulcer. If the patient comes from medicine, it's a case of vasculitis, acne. They may think this as an insect bite, bacterial and viral infections. If they come from the ENT department, they probably feel it's a malignancy. And of course, from the dermatology department, it has the maximum outcome. So like they treat it as acne, lupus vulgaris, leprosy, deep mycosis, histiocytosis. So all of these differential diagnoses come for leishmaniasis, as also for leprosy, as discussed by our Mahesh sir. So we need good diagnostic setup and surveillance for diagnosing all these conditions in our country. So these leishmaniasis, they are associated with malnutrition, population displacement, deforestation, poor housing, climate change, and a weak immune system, and lack of financial resources, which are very much similar to our setup. So these cases must be what we are seeing, maybe just the tip of the iceberg. So, and the diagnosis is mostly symptomless. And if symptoms persist, they come to us with a sign of erythema, a papule, or a non-healing raised scaly lesion, that too in the face and the exposed area of the body. And if it is 1 or 2 months older, the lesion comes as an ulcerating lesion. And some may have a secondarily infected staph infection. So there's a great heterogeneity in infection level. So, and we should, this topic is very important, because we should know that according to the species causing this infection, it may transform either into visceral leishmaniasis or mucocutaneous leishmaniasis, and even visceral forms may change either. So the specificity and sensitivity of test also depends on the species involved. So it is very important for us right now to identify the species. So talking about this is CL endemic in Nepal. So I think the criteria or the definition for endemicity is a full cycle of transmission has to be demonstrated in a place at a point of population we are studying. So I think in Nepal, the CL diagnosis is very difficult right now. And at any given time, a maintained population of competent vector plus parasite reservoir and locally acquired cases has to be found out. So I think now for us, the case identification is the most priority right now. Because to say it's an endemic thing, we need to at least one locally acquired case in the last 10 years. So as for my experience in this Western region, I get every one case from the Hilly region every week. So I think the case is still to be proven, has to be endemic in this region. So when we see the 2012 WHO map, the leishmaniasis is not there, so not available or not applicable in our maps, in our country's map. So when we go to 2014, there's no reported CL cases. So again, when we go to 2015, so it's again not reported. So it may be under-recognized, under-diagnosed, or under-reported. But I must not say that it does not exist. And there were very limited studies as case reports from our country. And these cases which were reported was the cases coming from abroad, or they had a travel history. So similarly, first case was also in a Nepalese patient. So this also was there by Pandey BD. So these all cases had a history of travel, and it was in the adults. So similarly, this leishmania major as a cause was identified in some case reports, and cutaneous leishmaniasis was there as case reports from which was coming from other countries. Now, the disease has its clinical features mimic several other common or co-endemic diseases, as we discussed, and so the accurate pathological diagnosis is very crucial for starting the treatment, as the treatment for these diseases are very toxic, and so up to now the diagnosis of methods like RDT and bone marrow studies. But the cases of cutaneous leishmaniasis are not picked up by these RDTs, rapid diagnostic tests, and bone marrow is of no use. So the major problem here lies in diagnosing cutaneous leishmaniasis in our part. So this diagnosis remains a great challenge, especially in a country like Nepal, with endemic and poor geographic regions, and where the disease identification, diagnostic tests to be used in screening, and species identification is the present day demand for us. So there is an article in the Microorganisms 2020 about the laboratory diagnosis of leishmaniasis. So it has divided into microscopy, this antibody detection, and molecular diagnosis. So this is a very this is the demand. This is the present day demand for us, and the WHO has said that the gold standard technique is MLEE, that is multilocus enzyme electrophoresis, which is the only method able to discriminate all species causing human leishmaniasis. Other techniques are tedious, requiring isolation of the parasite, cultivation, and then protein detection in the host. So where are we in Nepal? So in Nepal, the national lab uses this RK39 RDT. So this is a recombinant protein which is derived from a specific antigen produced by the Leishmania donovani complex. So it is used. This has been used for the last 2 decades for serodiagnosis of visceral leishmaniasis in Nepal. So this is either used in a strip test or an ELISA-based method. So we are using this as a serum in Nepal, but it can be used for sputum, urine, and even saliva. So these strip tests have limitations. So the patient can have antibody present for months after cure of disease. So it will not detect whether disease has this recurrence, or this active disease, or this is a latent disease. So also the test can detect antibodies in the sera of asymptomatic patients. So the false negative results have been reported and may vary from location to location, and it has cross reactivity with malaria and tuberculosis. So these tests would not be of help in diagnosing cutaneous leishmaniasis or even visceral leishmaniasis for us. So a newly developed assay based on the detection of antibodies to the RK28 specificity is same as the RK39 test. Now, so where lies the problem in our country? So this leishmaniasis is a neglected disease. It's a clinical dilemma. It has a varied presentation and mimicker of other dermatological conditions. And there's a problem of biasness. Like if it comes from the dermatology department, they have a differential diagnosis as cutaneous leishmaniasis. But if it comes from other department, they don't give this DD as leishmaniasis, and the lesion may be biopsied, where the parasite may not be visible according to the parasitic load or the stage of the disease. So these are some pictures, and this was the children who had a lesion in the tip of the nose. There was another child with a lesion, a small nodule in the lower lip and the cheek region. This is another child, so having a lesion in his arm, and then in the angle of the mouth, the other child in the chin lesion, she also had the submandibular lymphadenopathy. And these all children came from the hills. They all were referred from the hills. And this man, he was referred from the surgery department with query dysplasia. So he was a chronic smoker and who died after 1 month. So maybe we missed visceral leishmaniasis in this case. He was diagnosed as cutaneous leishmaniasis by touch smear. And this lady, she had 5 different lesions according to the time, and she presented with this lesion, and we aspirated, we just used fine needle aspiration cytology in detecting the parasite in all these cases. So these lesions had been aspirated, and it was a tedious job searching for the parasite, but yes, we could demonstrate LD bodies in slides. And this was again a lady from Mugu, where there was an ulcerated lesion in her bridge of the nose, and we could demonstrate multiple intracellular as well as extracellular LD bodies in the aspirate, that is a fine needle aspiration in cytology. And this was a young boy from again the hilly region of Nepal, who had 3 different lesions in the bridge of the nose, in the lateral neck, and he also had a submental lymphadenopathy and in the abdomen region. So I think the abdomen lesion was secondarily infected, so it had a different presentation. And these are some intracellular mastigotes demonstrated by the fine needle aspirate cytology smears, stained by Giemsa smears. We can see few extracellular parasites. And now these are again a granuloma with the macrophages showing this engulfed intracellular LD bodies. This is again a beautiful granuloma. It's a very cellular aspirate, and we can see, I'm sorry for the image because it was all a mobile photography. So this again is a granuloma with multiple LD bodies. We are not lucky all the times because we do not get so much of parasitic load in all the patients or all the lesions. So in some cases we may get just one macrophage engulfing so many LD bodies, and we can see a eosinophil thereby. So this is again another child with 2 different lesions, ulcerating lesions with central ulcer. And this is a beautiful granuloma demonstrated by FNAC in this aspirate. This is a man from who was working in Jumla, and so he had a lesion in his lower lip. And this was the mastigotes demonstrated with a beautiful nuclei and kinetoplast in his smears. And so this was another lady with similar lesion. This is another child with the plaque-like lesion. And these are the DDs of this lesion. So this was a child and the old lady. They were both diagnosed as lupus vulgaris, and this was by FNAC again. So this is a recent child who came to us for diagnosis, but we couldn't diagnose, we couldn't demonstrate LD body in this case. So the challenge right now stands for these cases, whether these are chronic granulomatous lesion, and the clinician suspects this to be cutaneous leishmaniasis. But our laboratories are not that equipped to diagnose this. So I think PCR or a genetic or molecular diagnosis is a must for these parent denies biopsy for these kids of these lesions. And this is a misdiagnosed case after surgery, which was a case of leprosy, and which was not cutaneous leishmaniasis. And this was a boy who was working in India. So only this boy had history of going to India. Rest, all the other child were the indigenous inhabitants of the hilly regions of Nepal who had no travel history. And this boy with a unhealthy surgical wound had an operation, had a past history of operation in India, and he without documentation. So when we saw his biopsy, we could demonstrate the LD bodies. The smears are later on. So this was a case referred from medicine department. So this was a case of vasculitis. And this was again a case referred from the ENT department with suspicion of malignancy. But this was a patient from Rukum who was working in Lamjung after the earthquakes, and he was a case of cutaneous leishmaniasis with this central ulceration in the neck. And this is a technique which I use, and it's a very easy and user-friendly technique, very inexpensive and very quick. And so this is another child with the technique. And these are the skin biopsies. We are lucky to get LD bodies if the parasitic load is high. But if the parasitic load is very low, we may not detect the parasite in these biopsies. And other stains like pus stain, and then other DDs like fungus like histoplasmosis has to be considered in the differential diagnosis. And these are the LD bodies demonstrated by the H&E sections of the boy with the unhealing wound in his back I just showed. So these are few macrophages containing these LD bodies. This again the mastigotes of the parasite detected within the macrophage in a smear. We were very lucky to see a small ring-like lesion in the upper part of the field, demonstrating the LD bodies here. This is a beautiful granuloma with dot-like LD bodies we were supposed to see in high power. And so the difficulties in our series, like the difficulties of histopathology, was overcome by the simple aspiration technique. And we were able to detect LD bodies in all cases not visible in histopathology, and the cases which did not have LD bodies, we had a DD with like we had stained with AFB stain for demonstrating the acid-fast bacillus, and yes, the patient healed spontaneously with the treatment of the clinicians, and all the patients received treatment, and the treatment which they received was miltefosine if available, and if not available was itraconazole. So on follow-up, the lesions regressed or disappeared with the scarring. So in our FNST, we could demonstrate granulomas, some neutrophils, plasma cells, and a good number of eosinophils, intra as well as extracellular LD bodies, and GIMSA, and these all were the GIMSA stained smears. So these cases are alarming, and none have history of visceral leishmaniasis, and the RK39 tests in our cases were all negative. With one old lady just giving a positive RK39 test. So in the lady case, we don't know whether she had a past history of visceral leishmaniasis, though in our inquiry she said she had no history of prolonged fever, or she had no splenomegaly. So we don't know how that RK39 in that lady was positive. The rest other cases had no positive history of prolonged fever, splenomegaly, any other illness, and their RK39 was negative. So this histopathology is very tedious.
I'm so sorry to interrupt you in between, but due to time constraint, can you please wind up your presentation?
Yes, ma'am, I just finished. So this, our case was also presented in Italy, and we were awarded the best paper award. So we are, so now I just want to say that whether it is endemic, emerging, or underdiagnosed, so what we are seeing may be the tip of the iceberg. We have seen more than 50 plus cases, all from Western Nepal, and they deny history of travel. They all are children under 18 years of age, and none have history of visceral leishmaniasis or HIV co-infection. We performed, and RK39 RDT may be positive or negative. So where do we stand? Maybe latex urine tests may be our present demand for surveillance in the community, or we may also have to be doing immunomolecular study. So the gold standard is PCR. So these are the treated CL patient cases. So this was a lupus vulgaris boy, 4-year-old boy who was treated. And the province where I work is province 5, and the orange dots are the cases reported from province 6, 7, and 5. So since I've been working here since a long time, maybe we have been getting cases from these nearby provinces of Nepal. So maybe there are other cases around Nepal. So so this was the largest reported study of CL in Nepal, our article. So the guidelines has been changed after the article has been published. So in 2019, there's a chapter in the national guideline. So if it was not documented, I guess it would have never happened. So a randomized controlled trial is needed for CL in our scenario. And this chronic non-healing ulcer should be sent for pathology for special aspiration technique or histopathology or some PCR studies. So conclusion is a significant public health problem in Nepal, and it's neglected, misdiagnosed, mistreated, and missed even with histopathology according to the parasitic load or a non-healing ulcer, and simple aspiration technique may diagnose the disease. So the impact of the study is that the recent trend has become that cutaneous leishmaniasis as a differential diagnosis in all the cases referred to us, and it has a public health issue rather than a cosmetic issue, and elimination has been postponed. So without pathology, medicine is just a guess. So acknowledgements to all our patients, to all the treating clinicians, EDCT, Government of Nepal, FEDREC, and SODVELON. Thank you very much.
Thank you so much, ma'am, for your elaborate presentation on cutaneous leishmaniasis. So we have come to the end of this session, and we have one question for Dr. Mahesh. Am I audible to you, sir? Dr. Mahesh, am I audible to you? I don't think Dr. Mahesh is. Oh yeah, Dr. Mahesh
Hello.
is.
Yeah.
Am I audible to you, sir?
Yeah.
So the question is, what about the diagnosis of pure neuritic leprosy? Have you gone through some cases? Please share your experience.
Pure neurotic leprosy, we say that it is on the experience about, we can say, in Nepal and India, around we have 10 to 15% of leprosy, pure neurotic cases, and most of the time they are diagnosed very late because they have no skin lesion, only they have maybe the joint pain or somewhere nerve pain, uh, tingling numbness, it is there. And so one, we can say that neurologists, they do the nerve conduction and may that also help. And we say that it is on the expertise. We can say that clinical examination, it is very, very important. Nerve examination and a nerve function assessment can help us. Sometimes we do the biopsy from the nerve, and that we can, it is nerve, it is, we can do the biopsy, it is radial cutaneous, sural nerve, and if there is some cutaneous nerve, it is involved, then we can do. But in our experience, we find that even we do the nerve biopsy, very few cases are diagnosed from the nerve biopsy. Lastly, we can say that pure neuritic leprosy, it is our by experience, and neurological examination can help, and family history, those things we can say that. So these are the, we can say, but sometimes patient, we say it is leprosy, but they don't agree because they have visited several expert neurologists and those, so sometimes they are diagnosed as carpal tunnel syndrome or ulnar nerve compression. So maybe the orthopedic surgeon will do the nerve transposition, and lastly, once they develop the ulcer or deformity, then on that stage they are diagnosed leprosy. So it is, we can say, difficult for the dermatologist also, because nowadays people not very easily accept it is leprosy. Yeah. Thank you.
Thank you so much, sir, for sharing your experience on pure neuritic leprosy. We now take a 5 minutes break before we go to our panel discussion. We'll have a 5 minutes break, so stay with us. Till then, let's have a short clip made by us. You can have a beautiful view of our country. Please have a look to this video before we start our panel discussion. Thank you. We are now going to start our panel discussion. The discussion of topic is medical education in times of COVID-19 and its impact on dermatology. We have with us our moderator, Dr. Srishti Shrestha. She is the Vice Principal and Head of Department of Dermatology at Nepal Medical College. She has many publications in national and international journals as well. She has received World Congress Award of Dermatology 2019 scholarship, International League of Dermatological Societies Journaling Grant, and Faculty Research Grant by University Grant Commission. Over to you, ma'am.
Thank you, Manisha. Let me share the slide. Can you see?
Yes. Yes, ma'am.
Good afternoon and namaskar to everyone. I am Dr. Srishti Shrestha. I am here with a panel discussion on a very interesting topic, medical education in times of COVID-19 and its impact on dermatologists. First, I'd like to give a short introduction. With the COVID-19 pandemic in January 2020, the world was brought to a standstill, and there was partial lockdown in many parts of the world, and in countries like Nepal and India, there was a complete lockdown in many places. Because of that, education was affected badly. There was mass closure of schools and universities, including medical colleges. So there was academic crisis, basically because all medical colleges had to be shut in a very short notice. And this has hampered the traditional and familiar type of medical education which we were following for years. Now, when we talk about medical faculties, we were faced with two challenges. On one side, we had to deal with the pandemic, which was very new for all of us. So we were busy preparing on how to go about it. And the other side, those faculties who were involved in medical education had to get acquainted with online teaching methods. We had to go for online trainings and things like that. So the traditional form of teaching like didactic lectures, problem-based learning, peer-assisted learning, bedside teaching converted to online teaching. Because of that, the students as well as the teachers were faced with many challenges. So this is just a background of what we are facing right now today as well. Now I'd like to move on to the panel discussion. Let's meet our esteemed panelists. First of all, I'd like to thank SODVELONCON for giving me this opportunity to moderate a session which is very close to my heart, as I've been involved in medical education section for last 4 years. Besides that, I'm very much privileged to be a part of this panel discussion because we have esteemed panelists from different parts of Nepal and India as well. First of all, Professor Dr. Kaushal Verma is professor at AIIMS, New Delhi. He has multiple international and national publications, and I've met him personally many times. Welcome to this panel discussion, sir.
Thank you, Srishti.
Second, we have our dear Professor Dr. Dinesh Vinod Pokhrel, sir. He is a professor at Institute of Medicine. He has also multiple national and international publications. Welcome again, sir. And again, our dear ma'am, Professor Dr. Sudha Agrawal, Professor and Head Department of Dermatology, BPAKIHS, Dharan. She also has multiple publications in national and international journals. Welcome, ma'am.
Thank you. Namaste.
Lastly, we have Dr. Chandrasekhar Sirka, Additional Professor at All India Institute of Medical Sciences, Bhubaneswar. So it has been a pleasure to meet you virtually, sir. Welcome again. Now I'll start the panel discussion. First question is, how has COVID-19 pandemic affected the undergraduate teaching? First of all, I'd like to hear from Professor Dinesh Vinod Pokhrel. Over to you, sir.
Thank you, Dr. for this opportunity, and also to the organizing committee, Dr. Sabina and Manisha.
Dinesh, sir?
Yeah. Are you listening me? I have unmuted myself. Could you unmute from your side? I have unmuted. Could you unmute me from your side?
Dinesh, sir, can you unmute yourself?
Yeah, I have already unmuted, but someone has. I have already unmuted. Can you hear me now?
Yes, yes.
Yes. Okay. Okay. So I had unmuted, but from the organizer side, it was not being unmuted. Anyway, thank you very much for the organizing committee as well as Dr. Srishti for organizing such a nice topic of panel discussion and in a very relevant topic right now. And this is the first time that we have faced this COVID pandemic. So regarding the question, how has COVID-19 pandemic affected the undergraduate teaching? Of course, yes, as because there was the lockdown, it has affected. We had to shut down all the educational activities, including the theory classes and clinical postings as well. But to some extent later, when the lockdown was open, we could manage them with a small group discussion at the clinic and by the virtual meeting, all the theoretical classes, we could organize the theoretical classes. And some of the cases that they were supposed to learn clinically were emphasized on the virtual clinic, virtual classes, as well as on the group discussions, in the small group discussions in the clinic. And they did have, although not ample exposure to the patients, but they did have some exposure to the patients, selective patients, which they were thought to be to know about the cases. Okay, so this has impacted, and not only the learning has impacted, but the trade terror because of the COVID-19, because many of the students, even the residents and the undergraduate students, they were affected, their family members were affected, so there were a lot of mental panic on the family as well as the students, and same was with the faculties and the teachers as well. So this has somehow affected very much to the medical communities, including the undergraduate students. But at the same time, it has also brought up with some of the opportunities to learn the distance from the distance. Okay, so this has, I could say that this has not only negatively affected but also positively affected.
So we'll be talking about that later, sir. Okay. Kaushal Verma, sir. So your opinion on this. So you've been involved in undergraduate and postgraduate teaching. So we'll start with undergraduate teaching. How has it affected COVID in India?
Thank you, Srishti, and let me thank the organizing committee for inviting me to this important meeting. I would have loved to connect in person, but because of the COVID, we are meeting virtually. Nonetheless, it's an equal pleasure and good to see you all. Teaching learning has got seriously impacted because of COVID, and both undergraduate and postgraduate teaching has been affected by the COVID. The classes had to be completely suspended, and then the online system of teaching had to start. Their bedside learning became so impaired that many of the students in the last about a year and a half have hardly been to the wards. They have not seen the patients, and whenever they have been visiting also, the kind of patients and the number of exposure has been so little and limited that their training has got seriously affected. The theory classes could resume online, but the personal connect that you would have with the students, the body language, the emotional connect that develops while you're teaching, that is not possible, and it doesn't develop with online teaching. So the teaching is one component which was compromised, and then their learning on the patients got seriously impacted because many of the hospitals, they had to be converted into COVID hospitals, or they had to be majorly converted into, say, COVID care centers, and the other patients didn't have an opportunity. Some students did get a chance to get posted there, but they were not liking it, and also the exposure to the kind of patients was, say, almost similar type of patients. So undergraduate teaching got seriously impacted because of the COVID, and it has impacted everything else also. So we would be talking maybe about the postgraduate teaching in a little while from now.
Thank you, sir. Thank you very much, sir. Now, on to the next. So basically, with the closure of undergraduate teaching learning activities, there was loss of time. That was the most important thing the students felt. And besides that, in our curriculum, I guess in India too, dermatology is considered to be a minor subject. So in Nepal also, in TU, Dharan, Patan, it has some weightage, but when we talk about Kathmandu University, it's a very, very, very minor subject. So in normal times also, there is limited exposure in clinical postings. With pandemic, this problem has increased, which I felt personally. So as Sir said, that emotional connection with the students was lost during this time with online method of teaching. Now coming to postgraduate teaching, I'd like to hear from Professor Sudha Agrawal. How has COVID pandemic affected the postgraduate teaching, ma'am?
Well, Dr. Sudha, it's really very tough time when we faced the first lockdown. And there was like what you have mentioned, the hospital, our ward was also converted to COVID unit. And that time we faced to shift to the other places, and it was difficult for us to see our patients, to admit the patients. But no doubt, the teaching learning, particularly I would like to say about the clinical theory aspects, the seminar, short talks, then journal club. That continued, we started online, and it has found very effective. But no doubt, again, the problem is the electricity cut off. There is major issue. The another is the internet issue. These two we are still facing time to time. The another important aspect, and before I introduce this, we took the feedback how we are going to take care of this the teaching learning activities from our postgraduates, and then they also suggested the same way. So it is both way we take care from our side as well as from the student sides, and this we are able to some extent we are able to overcome. Later on, we introduced the clinical discussion also. So the limitations are there, but being a dermatologist, we are able to see the cases, the skin, we can make the diagnosis. But again, the communication skills, how the patients, they are dealing with the patients that are missing. And the students, how we are going to take the cases, like those who are in the ward, those who are taking cases, seeing the cases, they were able to take the photographs. And in the beginning, we are very much scared how to see the patients also. So we are the PPE was also a real concern for all of us. So this is two issues. The third is the case and the procedures, because the dermatology and the research thesis, like how they are going to do. So just what I want to highlight the clinical aspects, clinical cases. They were in the beginning, the number were less, but when we were able to open our hospital, the number is a few of the, like a month, they were not able to have the good number of cases. And then we have prepared our guideline, and it has published, and Dr. Sudeep Parajoli, he is the one who asked how we are going to take care of the procedure when in the hospital, in the department. So likewise, we started, and gradually we overcome this the problem of the procedure also. For under most important, we found the problem regarding the thesis part. The cases, a lot, the students were not able to get the good number of cases. So what to do? But fortunately, in BPKIHS, we have to, the resident has to submit their thesis at the end of second year. So we requested to extend their period, and they, to some extent, they were able to take care of their data also, the sample size. But definitely, it has affected our life as well as our discipline. But no doubt, we have to accept our new normal. The normal will not come. We have to accept this. And Professor Dinesh has already mentioned, we have always, the challenges always give the opportunities, and definitely we have the opportunity, we have to accept it, and we have done it. So thank you very much, Dr. Srishti.
Thank you, ma'am. Thank you, ma'am. Dr. Sirka, I think you've joined. So this, we'd like to hear from you as well. How has COVID-19 pandemic affected the postgraduate teaching? Welcome, sir.
Oh, good afternoon, everyone. So this, madam, you asking me?
Yes, sir. Yes, sir.
Okay. The COVID has really affected the same that it has affected in the other parts of the world. Challenges, but especially like now we have opened up for this thing OPDs, and we have been using masks and other procedures to protect ourselves from them. Same time, we are making the students check the things one by one. But however, we have made certain changes in the examination process. We have now tried to put an open book examination. The AIIMS Bhubaneswar has started. That is, we try to frame the question in such a way that a patient has been presented to them. So that is why they would not be able to copy directly from the book. They do have to see the case scenario, and they do have to write the answer and within a limited period of time. That is what we have made some changes. Otherwise, regarding the examination of the patient, it has really become a challenge because by morphology they are to make a diagnosis. They are not being able to perceive how it feels, what is the consistency of the lesion, what is the color. In the picture and others, they are not being able to perceive the exact color of that one. Because with the passage of time, it is creating a problem in perceiving the exact one. They are not being able to know that how it feels. When we say that the solid means it could be a paper-like solid or a cloth-like solid or a hard one, unless the palpate they cannot do. So it has really hindered the education of the postgraduates in many ways now to us.
Thank you very much, sir. Thank you very much. It's very true. Actually, when we talk about postgraduate students, residents, they were not, the residential program was not closed as such, but when we talk about India and Nepal, I think in many other parts of the world also, the residents were given the new responsibility. They were posted to COVID ward, COVID emergency, fever clinic, COVID ICU as well. So because of that, the dermatology training was decreased. And besides that, they had increased risk of COVID infections, and many of our residents also got infected. That is another point which was affected. And there was short staffing due to illness or quarantine, and there was increased workload to the residents. And again, indirectly or directly, the exposure to dermatology training as such was compromised. And besides that, the dermatological procedures were less in number. Thanks to the past executive committee who had come up with guidelines regarding approach to dermatology in case of COVID. So we followed that. Doing that also, gradually we started doing dermatological procedures, but despite of that, patients were also scared and residents were also scared. And lastly, the research part, as Professor Sudha told, thesis completion was a big challenge for most of our students because of less number of patients. We had to find different methods to get it completed. And talking about examination, like Sirka sir told, we also conducted 3 postgraduate examinations in the last 1.5 years. We also followed the way you mentioned. Now, the next question is, again, there are some disadvantages of online education system in medical field. So what are those pitfalls? I'd like to hear from Professor Dinesh. Dinesh, sir?
Yes. Are you audible now?
Yes, sir.
Okay. So definitely there are some pitfalls as the physical presence is most important in general educations, but while performing these online educations, the students may get enrolled in the online system, but after enrolling, they will just go aside. So the students are learning it properly or not. And we will not be in a position to interact with each of the students because we are not visible. Almost all of them are not visible in the online education system. That is one pitfall. And besides that, the technological part is another pitfall. Many of the students and many of the teachers as well are not much more tuned to the online education system. So they had to be taught first, okay, how they had to learn it, and they had to be taught first how to go ahead with the online education system. And same is true with the quality of the net system, as because many a times we don't get the band that is needed, the exact band that is needed to qualify the content of this medical education, as because it needs a very good quality of the pictures and sounds as well, and without interruptions. Many a times there is interruptions in the net systems. And so is true with the electricity. Sometimes it just go off in between and we may not be able to adjust it accordingly. So there are so many pitfalls with the online educations, besides the technology part, the clinical parts as well, because we may not be able to give them the proper analysis regarding the patients and laboratory investigations, procedural changes, aspects and all this. So definitely there are these pitfalls on online education compared to the physical learning.
Thank you, sir. Totally agree to you, sir. Because we can't, in a classroom where there are 100 students, that also an online, it's very, very impossible to monitor them. Half the class may be sleeping, someone may join and log out in between. So it was very, very difficult for us to monitor. That was one important aspect. And clinical classes, actually, it's impossible when we compare it to the physical classes we do. That's very, very true, sir. Moving on to the next very, very important question: how has COVID pandemic affected the mental wellness of the students? I'd like Professor Verma to give his opinion on this, because it's a very, very important challenge we've faced.
I think it has tremendously impacted the mental wellness of students and residents because of 3 or 4 important factors. One, that the loss of, say, their learning opportunities, and then their dislocation from the usual places to the COVID areas, and then stress because of, say, getting into work which they were not familiar with, looking after the COVID patients, getting posted to the ICU units and getting posted into the emergency, and then the fear of catching COVID infection during that period when they were posted into COVID positive wards. Patients, the family members getting, say, COVID illness, or somebody sometimes getting affected because of the COVID. So all these factors, their personal loss of, say, teaching, learning opportunities, moving to the areas which they were not familiar with, the risk of getting COVID infections, and then the other, say, issues which were always there with the COVID, particularly in the beginning of the disease when we didn't understand much about it. The fear was much greater. Many of the students were, the residents were taking leave, wanting to escape that, but they could not do much. They had to come back. Some were trying to delay this to avoid. And this all seriously impacted their mental health. And in fact, we had to set up the counseling centers for the students, for the residents, before they were getting into COVID postings, and say soon after they were coming back, and even during that period when they were posted there, we were asking them to connect with the friends, to connect with the family, to connect with the teachers. Anytime you have a problem, let us know so we can discuss it out. We can try to address this as much as we can. But despite all this, several of the students, they got into, say, serious mental issues, the breakdowns and the nervousness and the anxiety and even the depression. So all this have occurred in the students and residents.
Thank you, sir. Thank you. Very true, sir. Sudha ma'am, your opinion on this, please.
Yes, I agree with Professor Verma. It's really stressful for the postgraduate students. They have been posted in a COVID hospital, And in the beginning, they were not aware. There was no formal training how to take care of, there was no orientation how to take care of these patients. It is like you don't know the swimming and you have to be in the swimming pool. So that was the main circumstances they faced. Not only that, with the time the orientation was there, we were also able to know. I will say this is one of the most important we found. Then another is but we justified like they have to have the community posting. Like in our curriculum, they have to go to the community and the community posting has been stopped. So this is their community posting and we are going to consider as a community posting. So there is no as such problem of the duration of the committee. And this is changed to the COVID hospital posting. The another important that is there, the COVID positive. The students that they were positive, their family members were positive, that someone has died in the family. So how to take care? They have the limited number of the leave also. So how to take care of this part? And it was really challenging for all of us. But definitely we tried to overcome of all this problem. But no doubt, still we have to find out the solution for all these aspects, and there are many more, because after that they feel what is how to take care of the job, because once they are going to pass out, so really they are going to have, and because the number of cases are less, how they are going to earn. So it is ongoing, but definitely we hope we will get some solution for it. And we are getting some solution also. And one more thing that I just want to mention, the teledontology we have started, and it is like the one group of the students, they have take care of the teleconsultation. So that is a way we, during that full-blown problem lockdown period, so it was the teleconsultation was done by the department, and still it is continuing. So one group is taking care, so that way they are getting their clinical posting and taking care of the patient. But no doubt, the empathy, communication to the patient and attendant is missing if you have only the online classes and others. But definitely the mental wellness is really very important, and we have to see these aspects. Thank you very much, Dr. Sister.
Thank you, ma'am. So this was a letter we got from, an application we got from students after we started the online classes. There was a long list of complaints. So in a country like ours, where many students are from rural areas, the internet availability and connection issues was the most important, and it's very difficult for them to catch up with the pace of the studies. It's very, very difficult. And the other is the health issue. Most of the students were complaining of headache, eye strain, and finally, there were so many factors which led to mental health issues. And till now, at this moment also, many of our students are going on and facing these issues. I'll not highlight the issues because they have already been told by the experts. Now, moving on, Sarkar sir, how has COVID-19 pandemic affected the faculties and teachers? We have talked enough about the students. Now it's the turn of faculties and teachers. So what are the factors which has affected the faculties and teachers, sir?
The problems have been same for teachers too also, because in our institutions, like most of the teachers were posted for the COVID duties also simultaneously. They do have the same problem. Now the teachers do have really a problem with us in the same institutes where I work, is that we had a different state of people because of the COVID, because there are people who were at least relatively trained better than the people, those who joined later during the COVID time. So these people, the people, those who had joined before, they had some idea regarding what is endometology, what is to do this one. But these people, those who joined later, they were not having an idea. They were having a fear is that they have come to this institution for learning endometology, and now they have been constantly been posted in the department like COVID duty, COVID center and all where. They were totally lost. On the top of that, we were having a telemedicine. With the telemedicine, they were not been able to learn what is to be seen, what is to be palpated. We are talking about some tests, if you do a junk test, then it will be okay. If you do a Nikolsky sign, it will be the same. But you cannot demonstrate them. Only a few patients were coming in through the casualty, but they were not good enough to teach them everything. So we had really a problem both when a faculty doesn't find the way to teach then he also has to search for an avenue how to teach them. So it was really challenging for us, but we do not know how to do it. But in some way, we were trying to demonstrate them in other patients how to do in Nikolsky, in an individual patient. But unless you see, you won't be able to convince your student that what you were trying to mean or what you're trying to show him. Because this is the demonstrating on a normal individual is not going to help on others. So this was the challenge that we had as a teacher. Otherwise, whatever the students, they were having the mental and other things that we talk in connectivity, that having an internet, these problems were there because these are new to the faculties also.
Thank you, sir. That's very true. We, faculties as such, were a bit of technophobic, I should say. We were not used to, most of our faculties had that fear, so there was insufficient logistical experience and knowledge to conduct online classes. And we felt that it's impossible to replicate the real-time feedback, debate, discussions which we used to have. Then student assessment was a very big issue initially. The other important thing is what we are doing right now, is it like correct method, or there is still lack of evidence what we are doing, is it correct or not? That's a big issue. And lack of facilities for simulation-based learning is another issue. Then coming to infection as such, COVID infection in self, family members, loss of loved ones due to COVID, practical problems in the family for mothers and fathers. If you have a child, they're having online classes at home, you can't leave them, there is no time, so many issues are there. And all this finally led to pandemic-related anxiety, stress, and it's still going on in each one of us right now. Now, we've talked lots about the negative aspect, a little highlight on the positive perspective of COVID-19 pandemic. Dinesh here, sir, your view on this?
Okay. Yes, of course. For every action, there is some good reactions as well. It has been seen in this COVID pandemic as well. And we had to explore a lot about the teaching learning activities, to adjust to family issues, to adjust in a very meager stage, like the unavailability of the things, like even the PPEs and all these were not that very sufficient. And so we have learned a lot, and we have come up with some good encouragement regarding the future aspects in such a pandemic as well. So what I think is we have learned a lot regarding the educational aspect, like distance learning, synchronous type of this distance learning and asynchronous type of distance learning, and assessment of the students with some OSCE-based and OBE-based materials and tools we have developed. So we have to be able to assess them in future as well. And similarly, we have been able to learn the utilization of these distance learning technologies as well. So many of the teachers, we were not attuned to such things. We have been able now at least to handle all this efficiently. So there are so many things, and also we have been able to encourage our youngsters and the juniors regarding all this. So I think this has also impacted positively to some extent for us, and we have a greater hope for learning in future as well.
Thank you, sir. Very true, sir, what you said. Now, I'm running out of time. So the last question is for all the panelists. So the COVID-19 pandemic is not over yet. So what is your advice for future of medical education in the field of dermatology? I'd like to start from Verma, sir. Your advice, please.
I think COVID has created and given us new opportunities, the scope for new learnings, and that we can continue and we can inculcate our teaching learning system. The important one is the online, where you can connect with anybody, anytime, any corner of the world, where you can effectively communicate, despite, say, without having the physical or the emotional connect, but you can reach out to people. So that is one of the big advantages, and also it has given us opportunity to work under situations which have been tremendously difficult, and it has shown the adaptability of the resilience also. That yes, the challenge is there, but it can be overcome. So with that mindset, people can start approaching the future problems, and in the medical education, what we lost, I think in the near future we would be able to say cover it up, because we now know that yes, the COVID is here and it's not going to go completely away. We have to live with this, and whatever progress the science has done and whatever opportunities, good in the sense, have been created, that we adopt and we move ahead. Online system should be the part of, say, the regular training program, which can partly be used, and but the bedside teaching and the hospital-based teaching learning, which is core for the postgraduate teaching, that got seriously impacted. So we should try to recover that, and we should try to reach out to the different areas where the compensation or the training can be compensated in that sense. So we'll have to do this mixed, the online and the physical or the in-person training. But clinical specialties, they both require, and they do require that the hospital-based training has to be there. So these modules have been developed in that process, which can be used, though they may not be in a real sense give the feel or say the kind of training to the student, but at least they can. So I think the hybrid thing is the future.
Thank you, sir.
Thank you.
Sudha ma'am, a few words from you.
Yes, I agree with Professor Verma. Like, it is a hybrid is needed, and I can say even in the class, online class, it is the asynchronous and synchronous both. If you do like asynchronous, that electricity part, if you have the already recorded one, you can take care, and later on you can join and you can ask the students the questions answer sessions, and so that you can make it more interactive sessions. So that is, I can say, even in the class you have to have the hybrid. Even in the clinic, I think we have to develop the module, so that for the particularly for the undergraduate, I can say for the postgraduate also, because we have to have if we are going to take care, online has, or I can say the virtual has its own advantages. So we cannot ignore the real one, but hybrid is the one that is really the best, and we have to develop officially the module for the postgraduate as well as the undergraduate students.
Thank you, ma'am. Thank you. Sarka, sir?
Yeah, I do agree with the previous panelists that only we do have to do is that probably we may have to put a problem-based question, so that if they wanted to give an exam, they can give an exam, but they won't be able to copy it down directly from the book. They do have to use their brain to do that one. And maybe what currently we have been doing is that we have been admitting some few patients, those where we want to demonstrate. We are trying to see that they are COVID negative, and then we are admitting them and we are trying to demonstrate them. That's what we are trying to do to a certain extent. We are not been able to do in a large number of patients, but we are able to admit some of the patients, and after a COVID test, then we are trying to demonstrate them. But I think so the bottom line is, again, we do have to give this telemedicine teaching has to be continued for quite a long time. And the open book examination might trigger the students that they do have to take interest on the clinical teaching also.
Thank you, sir. So to conclude, first of all, we must appreciate the flexibility shown by all our colleagues, our professors, all our faculties who have taken this new technology with ease. I think a big applause is needed for all of them. But multiple challenges are still there. We have to move on. But identifying challenges is the first step in converting them into opportunities. And I think it's time for medical schools to revisit and redesign their curriculum to more adaptable programs, like the panelists said. Some kind of hybrid learning should be inculcated in the curriculum for continuing medical education in the event of any disaster which may require containment in future. So maybe we may come up with something like this in future. A big thank you to all the expert panelists. This is how we conducted an postgraduate examination 2 weeks back. A food for thought at the end. The end of education, especially professional education, is not knowledge, but appropriate action. So we have to think about that for future. Thank you very much. A big namaskar to all of you. Thank you very much.
Thank you. Thank you very much.
Thank you, Srishti, for wonderfully doing it.
Thank you, sir.
Thank you, our esteemed panelist and our moderator, Dr. Srishti Shrestha, for the discussion on medical education in times of COVID-19 and its impact on dermatology. Now, moving on to our next session of presentation, I'd like to request Dr. Sanju Babu Shrestha to join us. Dr. Sanju Babu Shrestha will be presenting on laser in melasma. Dr. Sanju Babu Shrestha is currently affiliated to Nepal Medicity Hospital and is head of department in the Department of Dermatology. He has got 5 national publications and 1 international publication in his name. He has received hair transplantation and aesthetic training from South Korea. Now I'd like to hand over the screen to Dr. Sanju Babu Shrestha. Thank you.
Good evening. Am I audible? Hello?
Yes, sir. Yes, sir.
Okay. Good evening. Thank you very much, SODVELON, for giving me this opportunity to speak something about the lasers in melasma. I can see lots of my respected teachers and professors in the audience pool. I'm really getting nervous now. But it's a very good opportunity to present lasers in melasma. I have no conflict of interest to disclose. And we all know that this melasma is one of the well-described and distressing acquired pigmentary disorders characterized by the symmetrical hyperpigmented macules on the face. And no need to tell about the melasma. Everybody, after seeing the case, everybody can diagnose it. But the thing is, its pathogenesis is complex. That interplays the various factors such as genetic predispositions, ultraviolet radiations, hormonal factors, drugs, thyroid disorders, and vascular components. It's notably difficult to treat, and it has a tendency to relapse. The topical medications, traditional treatment, what we do is topical medications, and sometimes what we need is the systemic drugs. And if the person is not getting improvement with only the topical medications, then we use the chemical pills. But you know that this melasma is refractory and recurrent in nature, and in that situation, the patient seeks the alternative treatment, and in which we choose the laser therapy as another modality of treatment. The lasers that are used to treat a wide variety of cutaneous hyperpigmented disorders via the photothermal, photomechanical, and ablative mechanisms. And the successful and safe clinical application of this laser device requires the thorough knowledge of the principles that governs interaction between the light and the skin. Unless and until you know the skin and the lasers, then it's difficult to judge which lasers to use and where to use. The principle after this photochemotherapy is we have three things that we need to know. That is, one is the wavelength, second is the pulse durations, and third is the energy. The wavelength of the light is preferentially absorbed by the target molecules, also called the chromophore, and the light must be delivered within a period of time that limits the damage to the target and adjacent cutaneous tissue. The light energy transferred to the target chromophore must be sufficient to exert the direct desired therapeutic effect that minimizes the damage to the adjacent tissue. These are the three things to remember. This is the diagrams to show how does this laser light act. By this laser irradiations, the pigment cells, they become disrupted, and the disrupted pigment cells, they usually get eliminated through the skin surfaces. The pigmentary lasers which we use for the lasers, which we use for the melasma are most commonly Nd:Ag laser, having a 532 nanometer and 1064 nanometer wavelength, and another is Q-sweet ruby, Q-sweet alexandrite. The other lasers which are being used as a pigmentary lasers are the non-ablative fractionated resurfacing lasers, ablative fractionated resurfacing lasers, picosecond lasers, and pulse dye lasers. The Q-switch lasers, they usually produce high intensity laser beams with very short pulse durations, and the speed is amazing. That is 1 million times that of the IPL pulse. About the Q-switch Nd:Ag laser, which we use almost very commonly in our clinic, and this is the most common lasers in melasma. It has having a dual wavelength, that is 1064 nanometer, and that is used for the dermal lesions, as well as the 532 nanometer for the epidermal lesions. The advantage of this laser is it works for the dermal melasma, which cannot be treated by only the topical therapies, and the treatment time is very less. But disadvantage of this laser is post-inflammatory hyperpigmentation and recurrence of the melasmic lesions. There was a study done by the Watanabe and et al. They studied the 22 Asian patients, 5 weeks treatment of the Q-switch Nd:Ag laser with or without hydroquinone, and the result they found was with the Q-switch Nd:Ag laser along with hydroquinone, there were a 93% improvement, while only in the monotherapy with the hydroquinone, only the 20% was improvement. The MASI score reduction was around 76% in the former and 25% in the latter. The side effect noted was the same: the motile hyperpigmentations, rebound hyperpigmentations, and the notably recurrence was almost 100%. So similarly, another study, 40 patients, 10 nuclear treatment with Q-switch Nd:Ag laser by Koi et al. There was a mass reductions by 55% from the baseline. Response rate was 75%. They had the clear improvement, while the 10% had the only 10% had the no improvement at all. The side effect, motile hyperpigmentation and the rebound hyperpigmentation also seen over here also. This is the one thing, laser tuning, that is becoming very popular nowadays. The laser tuning or low fluence multiplex technique that is popular method for the treatment of the refractory melasma. The term laser tuning comes from the improvement of the skin tone that results from the use of the laser. Here we use a collimated low fluence Q-switch Nd:Ag laser, 1064 nanometer wavelength. The mechanism is they causes the subcellular photothermolysis, and there is no cell death. That is the things to remember. And only the minimal inflammation will be there. How we perform the laser tuning procedures is we choose 1064 nanometer wavelength lasers. Spot size is 6 to 10 nanometer. Fluence is 0.8 to 2 joule per centimeter square. Frequency is 5 to 10 hertz. And the most important thing to remember is the handpiece should be perpendicular to the skin and should not overlap more than 10 to 15% between the two pulses. The end point of the treatment will be the faint erythema. Another thing to remember is darker the melasma, the lesser will be the fluence and vice versa. This is the thing to remember. The minimum of 10 to 12 sessions with weekly interval or fortnightly interval can be conducted. After procedure, broad spectrum sunscreen has to be given to the patient and they can resume their topical after 1 to 2 days of the procedures. This is a very short video of how we perform the tuning in a patient suffering from the melasma. The advantage of tuning is it's a very effective treatment, but the disadvantage of this is there is always a chance of recurrence. The side effects are very minimal, but notably they may be of hyperpigmentation, gutted, leukoderma, physical urticaria, acneiform eruptions, minute petechiae, whitening of the facial hair, and herpes simplex reactivations. And these side effects may be minimized by the using a larger spot size of 10 millimeter with a longer interval about 2 weeks between the spaces. Similarly, this tuning was time studied the effect of laser tuning in large number of the cases, about 38,970 cases, where 56.3% had a fair improvement, 22.3% had a good improvement, and 5.1 had the excellent improvement. Only the 7.9 had the little or no improvement. This is another study which I will skip. This is a picture showing the how we do the laser tuning in our clinic. This is another one doing carbon peeling. These are the few photographs to show the effect of the NDAC laser tuning before and after. We don't do only the laser, but we do the combinations of the treatment, like the topical therapies, sometimes adjunct with the chemical fields, and the patients who are resistant to the treatment, then we perform the laser tuning as well.
I thought panel discussion. I was only on the panel discussion, no? I was only on the panel discussion. Which talk? I didn't know. I didn't know the talk.
Hello?
I didn't know the talk. There is no talk. I didn't receive the letter. Only this letter I have received. There are no talk for me.
Hello?
Okay.
MC?
I'm not prepared for it because like now I haven't.
Can I continue?
Yes, sir. Yes, sir. Sorry for the interruption.
Other lasers which we use are the picosecond lasers, which is a very new in our dermatology armamentarium. And I'm very proud to have this laser machine in my clinic as well. This is a very recent innovation in laser design. This is really recent innovation. Why? Is the laser design has generated picosecond domain pulses. And the mechanism of action is the shorter laser pulse duration results in the pigment fragmentation that is more as a result of the photoacoustic than the photothermal effect. This is the difference between the Pico and the NDAC, QCT NDAC laser. This is more efficient at the pigment removal without inducing a thermal damage, so there will be less chance of the side effect. We have used this 532 nanometer and 755 nanometer and 1065 nanometer in the picosecond lasers. The advantage of this laser is they causes the less amount of the post-inflammatory hyperpigmentations in comparison to the Q-switch lasers. And there is one study that shows the 1064 nanometer Q-switch laser versus picosecond lasers, in which the 755 picosecond laser could be the safe and effective modality for the melasma treatment in the Asians. I'm not skipping this because of lots of studies are there. So this is how the picosecond lasers act in the photographs. I am trying to show it. Because of the nanosecond laser, they rely on the photothermal action and they disintegrate the target tissue, while in the picosecond laser, the pulse triggers the photomechanical effect, they disintegrate the particles. Similarly, in another study by the Wong, they studied the 20 patients of the skin type 3 to 4 with 9 sessions of picosecond laser, and what they found is over 70% of patients were satisfied with the treatment outcomes. And there is a statistically significant improvement in modified MASI, which reduced from 10.8 at the baseline to the 2.7 and 3.6 at the 6 and 12 weeks post-treatment. For the skin rejuvenation, 70% reported at least a moderate improvement at the 6 weeks of post-treatment. There were no major side effects. Erythema was the most frequent transient response, with some patients, they developed edema, but both resolved spontaneously. Now come to the fractionated resurfacing lasers. We have got this non-ablative fractionated surfacing lasers and ablative fractionated lasers. In non-ablative fractionated lasers, the mechanism by which this act is they produce a mid-infrared wavelength that penetrates from the dermo-epidermal junction to the mid-reticular dermis, maximum depth approximately the 1500 microns to induce the neocollagenosis and remodeling. The transepidermal elimination of this microthermal treatment zone, in which post-treatment is hypothesized to facilitate the removal of the dermal melanocytes. They try to remove that. And there will be no visible ones. The wavelength which we use in the non-ablative fractionated resurfacing lasers are the 1440 nanometer, 1540 nanometer, 1550 nanometer, and this 1927 nanometer. The recovery is very rapid, almost 3 to 7 days. There is a less risk of discarding or dyspigmentations. The disadvantage of this non-ablative fractionated resurfacing laser is there will be the edema and erythema after the laser surgery. So this is a study done by the Kroon et al., where there is a direct comparison between the non-ablative fractional lasers with the 1550 nanometer and triple therapy topical film to treat the melasma. They completed the random control observer blinded study. In the 20 patients having a Fitzpatrick type 2 to 4. And in the results, what they find was the response was equal in the both groups. Treatment satisfaction and recommendation higher in the laser groups. Recurrence 50% of treated patients in the both groups at the 6 months of interval, but there was no complications from the PIS were reported. So what they conclude was 1550 nanometer laser was safe and comparable to efficacy and recurrence rate with the triple therapy, which we say that's the Kligman's formula. I'm concentrating on this BV laser, Lavin. This is a thulium laser. And in the study of this thulium laser by Podlar, KD. They study the treatment of melasma using a novel 1927 nanometer fractional thulium fiber laser. This was a pilot study where the 14 patients with the melasma treated in 1 monthly interval, 3 to 4 per sessions, in the setting of the 20 to 30 millijoule and total density is 250 to 54 microscopic thermal zone per centimeter square. In the results, the massive scores improved 51%, 33%, and 35% 8, 1, 3, and 6 per month after the completions of the treatment series, respectively. The side effect erythema, edema, microcust formation, but there is no scarring. And they concluded 1927 nanometer, this non-ablative fractional laser may be offer a safe and effective treatment for the patient with melasma. I'm sorry for this, all the numbers, but these are the few studied, which I'm skipping now. The advantage of thulium laser is they are more durable response compared to the IPL and Q-switch lasers. There is a less recurrence. Even after 3 to 6 months, there is a mild melasma appearance, but if you compare with the Q-switch NDX lasers, this is only after 3 months of the treatment, you will have the melasma recurrence. This thulium laser is very effective in the wide range of skin conditions, like up to 3rd to 5th versus in IPL and Q-switch lasers. Another lasers which we use for the treatment of the melasma, but sparingly, is the carbon dioxide lasers and RBM-AG lasers. The mechanism of action, how this carbon dioxide laser acts is, carbon dioxide laser emit the wavelength which is strongly absorbed by the water in the skin, and the penetration depth is dependent on the water content and independent of either melanin or hemoglobin. RBM-AG acts by the energy by water that is 10-fold more efficient than that of the carbon dioxide lasers. The advantage of this lasers are that they decrease the amount of epidermal injuries, there are fewer side effects, and there is a less risk of dyspigmentations. But the disadvantage is they develop the post-inflammatory hyperpigmentations, recurrence. These are the lasers, generally, they are not being used very frequently. They are not being used for the melasma patients treatment. Another few studies, I'm going to skip this also because the laser, carbon dioxide laser, we are not using much in the case of the melasma. The other laser which we use for the melasma patients are the vascular lasers, because this melasma has the vascular etiology, vascular pathogenesis as well, in which we use the pulse dye laser, PDL lasers having a 585 nanometer copper bromide lasers, and they have the very mixed results. So they overall target the vascularity as a treatment for the patients with the melasma. Those patients who have not seen the significant improvement with the other treatments. The other use of the lasers, which we can use for other purposes, like we can use this laser-assisted drug delivery system. That means some of the topical creams which we use, they are not absorbed adequately by the skins. So after doing fractional lasers, we can increase the bioavailability of the drugs. That's how we can increase the drug delivery and the effect of the topical therapies. This is just a mechanistic overview of the melasma pathology and effect of the topical. The only one thing I need to emphasize is there is an entry pathway, there is exit pathway for the melasma. Entry pathway where the melasma lesions may be increased, and if you block the entry pathways by the drugs, then the appearance of the melasma, appearance of the lesions of the melasma may be reduced. And there is a exit pathway which we use by the lasers and the lights. Now, come to the main thing. We are investing millions of dollars for the laser treatment each year. And our question is, does the laser treatment help to the melasma? And if yes, what is the best laser treatment for the melasma? This question, the answer to be still to be found, because none of the lasers which I have mentioned before, they maybe the treatment, maybe the results are very short, and they are not the results are very not they are not good at all also, and they are not long lasting also. So my concern is lasers should be only considered with other treatment combinations. The one thing to remember is the choice of laser is critical for the safe and effective treatment. As we know that melasma cannot be cured, but it can be definitely be significantly improved by the treatment in the majority of the cases. And this is my advice to the dermatologists planning for the laser treatment for the melasma. They need to think for this. The first thing they have to think is what laser needs to target, which are our target tissue by the lasers, and what is the surrounding tissue color, the way the skin should just look after the treatment, the other medical condition that patient may have, post-treatment skincare, and so on. These are the few things you have to remember before planning the laser treatment. If somebody comes to a clinic and start directly, okay, go for the laser, that is not the way you have to go for. It's because of the unclear etiopathogenesis and recurrent and relapsing nature of the disease. The treatment of melasma is extremely difficult and frustrating by the treating physicians and by the patients as well. Dr. Saab, nikai vana, feri farke raayo. That is always one answer by the client we hear every day or every alternate. So the thing is, laser alone will not help the melasma magically melt away, because every patient wants my melasma go away by like a magic. But this is not a truth that cannot be done to the patients. So the topical therapies, physical therapies, even oral treatment might be needed to the patients to treat the patients of the melasma. So lastly, one old saying that goes, prevention. We need to prevent before the melasma comes. So the old saying is, an ounce of the prevention is worth a pound of cure. The same is true for the melasma. Thank you very much.
Thank you, Dr. Sanju Babu Shrestha, for your presentation and highlighting the importance of different types of laser in melasma management. Now, moving forward with the program, I'd like to request Dr. R.Y. Prasad Manseli to join us. Sir will be presenting on, oh gosh, it's a melanoma, what should I do? Talking about Dr. R.Y. Prasad Manseli, he is currently affiliated to Kent Integrated Dermatology Service and is designated as a consultant dermatologist at the institute. I'd like to request Dr. R.Y. Prasad to share his screen with us.
Good evening. Hopefully you can hear me well. Okay. I'm Am I audible? Is that okay?
Yes, sir, you're audible.
Okay, that's good. Thank you. First of all, I would like to congratulate the organizers for a brilliant effort in a very difficult time and keep the education meetings going on. At the same time, thank you for inviting me to speak on melanoma, which is a good part of my day-to-day dermatology work. So I have no conflicts of interest to declare. Melanoma is a very extensive topic, and it's quite difficult to talk about it in 15 minutes. So I've chosen the bits which are important for a dermatologist. Most of the melanoma cases, they start their journey in a dermatology clinic. So where we do the initial assessment and the initial surgical treatment. So that's what I'm going to focus on in the topic today. We will also discuss, once you made a diagnosis, how do you counsel the patients? When do you need to ask your colleagues, particularly the surgery colleagues for sentinel lymph node biopsy, or the oncologist for their opinion? And when do you request staging? So those are the decisions which the dermatologists are mainly involved with, so I'll be focusing on those. I won't talk about the stage 3 or the stage 4 management because they are beyond the remit of this talk. Now, imagine this, a patient presents to you with this sort of a lesion in the clinic. It does look fairly irregular, looks a bit ugly, looks sort of distorted shape with irregular margins. So obviously, you do need to think about melanoma for this sort of a lesion. So clinically, you suspect melanoma, and then so what's the next step? Obviously, you need to confirm the diagnosis. That would be by histological assessment. So there are some principles which you need to be aware of while doing a biopsy when you suspect a melanoma. Excision is almost always preferable over partial samples, except for some conditions which we'll talk about in a minute. The reason for excision is because it provides you with the whole of the lesion for assessment, which makes the breast flow thickness more accurate. The diagnosis is more accurate because you are assessing the whole of the sample rather than partially. Also, if a lesion is irregular enough for you to think about melanoma, even if the histology comes back not conclusive, you wouldn't want to leave the lesion alone. You would prefer to have the lesion removed. So for all of those reasons, I think excision is preferable over partial sampling. When you do an excision, it's better to take a narrow margin excision, or we would say about 1 to 3 millimeter, rather than a wide margin. The reason being, if you take a wide margin, that distorts the lymphatic circulation. So if you do decide to do lymph node biopsy in the future, then the lymph node biopsy may not be accurate. So for this reason, take a narrow margin just enough to completely excise the lesion. Also, you would need to think about how do you orientate the incision while excising them. You do need, because if you do confirm the diagnosis as melanoma, you would need to think about wider excision subsequently. And the wider excision may be up to about 2 centimeters on either side of the scar, so which is a substantial wider excision. So if you haven't orientated the original biopsy, then a closure might be quite difficult. Then you may have to resort to grafts or flaps, which are more difficult than a primary closure. So if the lesion is on limb, you would want to do it in a longitudinal fashion along the line of, along the axis of the limb itself, which will be easier for any further closure. Similarly, on the trunk, think about the way the lymphatics drain and also what would be easier to close subsequently. As I said before, incisional or partial punch biopsies might be sufficient or might be preferable, when you have a very large lesion, for example, a lentigo maligna affecting the whole of the cheek. So it would be practically not possible to take the whole lesion out. So in those cases, we would want a smaller biopsy. If you do that, then choose the area where the lesion looks most abnormal. And on occasions, you might want to do more than one biopsy to make sure you get a more accurate representation of the lesion. I would suggest avoiding shave biopsies completely when you think of a melanoma, because shave biopsy takes only the superficial bit of the lesion, which may not be enough to make a diagnosis. And even if you make a diagnosis, the breast thickness would almost always be inaccurate because you haven't included the whole lesion. The breast thickness is quite important for further management of the melanoma. So you would your treatment decisions might not be correct. So in view of this, avoid shave biopsies. If you have done an incision or a punch biopsy and the biopsy come back as benign, but you are still concerned clinically about a melanoma, then it might be worth repeating a biopsy. So now you've done a biopsy, you've done the incision, and the histology report can be one of three things. It can be, say it's a benign mole, or it might be a benign inflammatory condition, in which case it's happy news for you and happy news for the patient, and you reassure them and send them home. However, if it is a dysplastic nevus or a melanoma, that involves further treatment and discussion. Now, dysplastic nevus shows some pathological features which are not enough to make a diagnosis of melanoma. So far, the evidence to say whether a dysplastic nevus progresses to become a melanoma is not clear. I think most experts do believe that most dysplastic nevus themselves do not progress to form melanoma. However, if a patient has multiple dysplastic nevi, then that itself is a risk factor melanoma. So it's important that these patients are counseled for regular self-skin examination. So if the histology comes back as an atypical or a dysplastic nevus, and the atypical features are mild or moderate, once you have a clear margin, histological margin, no further re-excision is required. If it is incomplete, but clinically there is no pigmentation, you may choose to observe, but in most situations you might want to re-excise it just for reassurance. If the atypicality is quite severe and the margins are narrower than 1 millimeter, or if it is incomplete, I think most authorities would suggest a re-excision with a 5 millimeter margin to make sure that the nevus is completely removed. The controversies around a severe dysplastic nevus, where you got a clear histological margin of 1 millimeter, does it still need re-excision? I think this is a debatable area. In our practice, most of the times we do end up offering 5 millimeter wider excision, but some of the patients choose not to have it, in which case we advise a regular cross-check. So that's about dysplastic nevus. As I said, if they do have multiple dysplastic nevi, do advise them of regular self-examination of the skin. And if any of the lesions change, they do need to get it checked. Now, going on to melanoma, when you have a histological diagnosis of melanoma, always look at two factors. One is the breast lobe thickness, and the second is the presence of ulceration. Because these are the two most important prognostic features, and these dictate what you do with regards to treatment, imaging, counseling, and follow-up. So these are important features. So based on this, the primary tumor is staged accordingly into 5 groups, in situ or T1 to T4. They are again subdivided into A or B depending on the ulceration. T2 to T4 is very straightforward. A and B is either ulcerated or non-ulcerated. Whereas in T1, it's a little bit more complex. Any ulceration is T1B, whereas T1A is only up till 0.8 millimeter. Anything more than that it goes into T1B. I will not be covering the lymph node staging or the metastasis staging because that's beyond the scope of this talk. We will confine ourselves to the staging of the primary tumor as we'll be focusing on this today. So once you have a diagnosis of melanoma and you have the prognostic features which dictate the treatment, then you got to talk to the patient. So how do you counsel them? In my opinion, I think it's important to be upfront and frank and say that melanoma is a cancer, and because that makes you more open to the patient and the patient will listen to you more. So you convey the message more clearly. We do need to talk about prognosis and treatment, which we'll talk in more detail, and you will know what to tell the patient. These are important features. Now, this is the time to do a full skin check because if you have one diagnosis of melanoma, these patients are at a higher risk for a second melanoma, so you would need to check the skin completely to make sure there's no other suspicious lesion. It's also important to do a lymph node check, mainly for the regional lymph nodes, but I would check for all the lymph glands and also feel for the any hepatosplenomegaly. Generally, most early melanomas, we don't expect to find anything, but it's important to be thorough and do this examination. We do need to counsel them on regular self-skin examination to detect any further changes. Also look for the lymph glands, sun protection, and vitamin D supplements. However, the first appointment, in my opinion, is quite overwhelming for the patient, and most of the times they miss some of the details. So the self-care aspects may be covered at a later stage and to focus on the prognosis and treatment in the first appointment. Now the prognosis, these are the prognosis statistics based on the primary tumor stage, and this is from the AJCC 8 staging. However, note that from T2 to T4, this applies only to sentinel lymph node biopsy negative patients. So in your first meeting with the patient, once you have the histological diagnosis, the sentinel lymph node biopsy has not been done. So you wouldn't, these figures are not really accurate at that point, but it gives you a framework or a rough idea as to what to tell the patient. You would also need to mention to them that if they do go ahead to have the sentinel lymph node biopsy, that might change the staging and the prognosis itself. But I think this is a good starting point to initiate the discussion. If you want more information on the prognosis and the staging itself, this is a good article to look at. It is an open source and freely available on the internet, so you're free to check it out. Okay, so you've made a diagnosis of melanoma, you identified your prognostic factors, and you talk to the patient. So the patient will ask you, so what treatment does it need? The primary lesion itself needs wide local excision. The reason being, it gives you a margin of clearance to reduce the chance of recurrence of the melanoma. So far, the studies haven't exactly delineated the exact margins you need to take for each melanoma. However, based on the a few studies, this is the current practice. If it is an in situ, we would take about half a centimeter of margin around the lesion itself to get a wide local clearance. And the remaining, the Breslow thickness, anything less than 1 millimeter, 1 centimeter margin is adequate. 2 to 4 or more than 2 centimeter would be adequate. And there is a range of 1 to 2 centimeter for 1.1 to 2 millimeter melanoma. In our practice, most of the times we do choose 2 centimeter. However, for cosmetically sensitive sites or surgically difficult sites, we would accept a lower margin of 1 centimeter. This obviously would need to be done in a joint fashion with your patient, talking about the balance between the clearing the melanoma and keeping the melanoma from recurring on the cosmetic improvement after the surgery. Now that's the treatment of the primary lesion, and the next. But before you go on to do the wide local excision, you would need to have a chat about the sentinel lymph node biopsy. Sentinel lymph node biopsy is a procedure where you inject a dye into the primary melanoma site, identify the lymph node it drains into, take out that lymph node, assess for melanoma cells, and if there are melanoma cells, that indicates that the melanoma is spread beyond the primary lesion, and removing that lymph node reduces the chance of recurrence. Theoretically, it sounds very simple. However, in practice, so far, sentinel lymph node biopsy has not been proven to offer any survival benefit at all. However, what it offers is a very good prognostic tool, and it gives us an idea as to what is the possibility of the cancer spreading. So with that in mind, sentinel lymph node biopsy is not recommended for T1A patients where the risk of a positive sentinel lymph node biopsy is less than 5%. If the risk of a positive sentinel lymph node biopsy is 5 to 10%, you consider it, which is mainly T1B group. And T2 and above, because the risk of a sentinel lymph node biopsy positivity is more than 10%, these patients are offered. However, you do need to take other things such as age, comorbidities, and other factors into consideration before offering this. For T1A patients, although for T1B patients, although the risk of a sentinel lymph node biopsy being positive is 5 to 10%.
Excuse me, sir. No, sorry to disturb you. Can you please conclude your presentation due to some time constraints?
Yeah, sure. Thank you. So sentinel lymph node biopsy needs to be done at the same time as a wide local excision, so you need to consider that. Imaging is, there's no role for imaging for stage 1 or 2 patients where the sentinel lymph node biopsy is negative. However, if there is a stage 3 where lymph node is involved, you need staging CT scan. Ultrasound of any suspicious lymph node is indicated with a fine needle biopsy, and that upstages the diagnosis. So once you've made a diagnosis and treated the primary tumor, following that, you need to decide on the follow-up. Of course, if there is stage 3, you refer the patient for oncologist for immunotherapy. For T1A patients, we follow up for 1 year. For T1B and above, we follow up for 5 years. Hope this has given a very brief outlook on management of melanoma and how you assess the primary tumor, and hope you found this useful. Thank you.
Thank you, sir, for your wonderful presentation and providing an insight on melanoma. Thank you, sir, once again. We'd like to make a sincere apology for not being able to connect with Dr. C.S. Sirka for his presentation due to some unavoidable circumstances. Now, moving forward, I'd like to request Dr. Rasmi Sarkar to join us with the presentation on pearls and pitfalls in pediatric dermatology. Dr. Sarkar is affiliated with Department of Dermatology at Lady Hardinge Medical College, New Delhi, India, and she is designated as the Director Professor. She has got 125 journals in published journal in national journals and 75 international journal publication in her name. She has been awarded with President-elect IADVL 2021 Editor Emeritus, Pigment International. She has edited 16 books. She is a Vice President of IST, editorial board of 5 national and 5 international journals. Ma'am, now the screen is over to you.
Okay, are you able to see my screen?
Yes, ma'am.
Okay, so good evening, everyone. First of all, a very warm namaste from India. And I'd like to thank the organizers, especially Dr. Sabina and Dr. Manisha and so many others, Dr. Arpana, for inviting me here, all the other team members. And I'm going to talk about pearls and pitfalls in pediatric dermatology, which is very close to my heart. And as you know, I come from Lady Hardinge Medical College, New Delhi, which has its own pediatric hospital, Kalavati Saran Children's Hospital. This is the busy pediatric dermatology clinic out there, one of the largest pediatric hospitals in Asia. Well, my focus in this 15 minutes or so, you can't talk about everything. It will be on a little bit pearls on infantile hemangioma, molluscum contagiosum, little bit what is new and biologics in pediatric patients. So first of all, what about beta blockers in infantile hemangioma? We know that propranolol, a non-selective antagonist of both beta-1 and beta-2 adrenergic receptors, was US FDA approved in 2014. And oral propranolol hydrochloride is definitely used for proliferating infantile hemangioma requiring treatment. Now, regarding the mechanism of action, very quickly, it's multimodal and has vasoconstriction, angiogenesis inhibition, as well as induction of apoptosis, inhibition of nitric oxide production, and finally, it regulates the renin-angiotensin system. So what you have is a very early involution of the proliferating lesion. Now, what are the 5 major indications to consider early treatment or evaluation of these lesions? Definitely, these are life-threatening complications, functional impairment or ulceration and the risk thereof, evaluation to identify important associated structural anomalies, permanent scarring or distortion of the anatomic landmarks. Have a quick look at this chart on high-risk infantile hemangiomas, but what you have to remember is the life-threatening ones are the ones on the beard area, which means an obstructive airway hemangioma it could be, or more than 5 cutaneous infantile hemangiomas, which can have liver hemangiomas, cardiac failure, hypothyroidism, and so on. Those causing functional impairment like the periocular infantile hemangioma, or those involving lip or oral cavity, ulceration like the segmental infantile hemangioma on different sites, associated structural anomalies, segmental infantile hemangioma of face or scalp, or lumbosacral or peridial area. So we have to look out for these face or lumbar syndrome. Disfigurement is important, whether it's a segmental IH of the face and scalp, and whether it's on the nape, trunk, or even the extremity. And finally, infantile hemangioma, which can cause permanent changes in the breast development, asymmetry, or even nipple contour, which can affect a woman's quality of life later on. So there's a very strong recommendation, grade A, and clinicians should definitely use the oral propranolol as first-line agent for treating IH. Now, looking at a quick patient workup, an initial review by the pediatric surgeon and also by the pediatrician for the cardiovascular examination of blood pressure, heart rate, echocardiogram, electrocardiogram, blood count, prothrombin time, and partial thromboplastin time should be done. We also do the test of blood urea, nitrogen, creatinine, and electrolytes, liver function tests. And if you find it to be segmental or craniofacial, do an MRI to rule out the intracranial anomalies. Now, looking at the setup, I did my visiting, fellowship in the UCSF San Francisco Pediatric Dermatology Unit, and there, most of it was given in outpatient, FDA label sanctioned initiation in an outpatient setting for infants, more than 5 weeks of corrected gestational age. When would you really require an inpatient setting? Well, infants who are younger than 8 years with cardiovascular or respiratory comorbidities and poor social support. It's good to start the treatment early in proliferating stage, and there's better result before the age of 6 months with higher lesion regression. Looking at the route of administration, the route of administration is in most published studies is mainly oral, and it's available in 10 mg and 40 milligram tablets, which can be dissolved in water. For easy administration, patients should be advised to soak the tablets in 10 milliliters of water for 1 minute before crushing and not to filter the suspension. Intralesional drug injection also causes regression of periorbital IH. Finally, where if it is available, 1% ointment applied for cutaneous IH leads to regression in 85% of patients, and topical treatments definitely have much lesser side effects. So when you're starting the dose, it should be between 2 and 3 milligrams per kg per day, unless, remember, there are comorbidities like face syndrome or adverse effects like sleep disturbance, which necessitate a lower dose, grade A moderate recommendation. And as I said, incremental dosage increase should be there. Start by 1 milligram per kg per day for 1 week, increases 2 to 3 milligram per kg per day. Target daily administration as 3 divided doses. So this is the dose adjustment, monitoring, and the education. Monitor 2 weekly, later 1 monthly. Do the measurement with the measuring tape, photography, imaging, assess side effects, and counseling. Assess the change in the size, the color, the decrease in the ulceration. Recently, it has been seen that a lower dose of propranolol actually works better if the ulceration is large, and decrease in inflammation. Discontinue by serial halving if it is static for at least 2 weeks. And then, of course, we know that regressed or resolved for 2 weeks. So this is important. Now, this is a summary of key action statement for management of infantile hemangioma. You can read the article by Crouchuk et al. In Pediatrics. And remember, I mentioned the other things, but always evaluate patients for and educate caregivers. This is point 3D about potential adverse effects of propranolol, including sleep disturbances, bronchial irritation, and clinically symptomatic bradycardia and hypotension. Also remember that you can prescribe oral prednisone or prednisolone to treat IHS if there are contraindication or an inadequate response to oral propranolol. So these are some other pearls that you need to know. And if you again have a look, that is at the summary of comparative efficacy of various treatments, remember that propranolol has an expected clearance of 95% compared to topical timolol, which is 62%, intralesional triamcinolone, oral steroid, and finally controls, which is just about 6%. Now, what about atenolol and nadolol, which are selective beta-1 antagonists, and each demonstrated effectiveness on lesion size, width, and what else? Like here again, there is a little difference in efficacy between propranolol and atenolol, and greater efficacy of nadolol in a small study. And overall, there's a lesser risk of bronchospasm. But the issue here is that this is not FDA approved. What are the pitfalls or the side effects? It looks pretty safe, but remember to look out for metabolic side effects like hypoglycemia, continue the feeding in the child, cardiac, bradycardia, hypotension, tachycardia. CNS is important. Catch hold of the sleep disturbances, insomnia, drowsiness, crying episodes, and hypotonia. Pulmonary, gastrointestinal, in case there's too much of diarrhea or GI upset, withhold the propranolol, or gastroesophageal reflux. So this, I wanted to show you the case. This is something which is distorting a particular site. So in a small baby, about 9 months old, so this is nipple and areolar hemangioma, as you can see, with a very large ulcer. So child was again started on propranolol after 2 weeks of the dose, which was 1.5 milligram per kg per day. It was initially to start with about 4.1 to 4 centimeters in the largest diameter. it became something like 3.75 to 3.5 in largest diameter. Ulceration also went down. You can see the nipple is visible. The other side actually had a kind of a lump. When we looked at the Doppler, we found that it was normal proliferative breast tissue. So you have to see, remember that these breast hemangiomas are very uncommon nipple hemangiomas, and you have to think of underlying tumors like even angiosarcoma. We ruled that out. So this was after 5 weeks on 2 milligrams per kg per day. Ulceration has decreased, and the size has become about 3.75 to 3.5. After 4th visit, after 7 weeks at 2 milligram per kg per day, ulceration is pretty much filled up now, and it has reduced to about 2.75 to about almost 3.25. When you look at oral propranolol versus topical timolol, remember that systemic propranolol mainly targets endothelial cells, whereas timolol mainly the target pericytes. So like systemic propranolol, we should start it early, topical timolol, and it's used in both complicated and uncomplicated hemangioma. Systemic absorption is unlikely from transdermal absorption. Proper monitoring before and after with topical timolol is something which should be done. It has advantages, topical timolol, like cost, availability, ease of administration, and very less side effects. So diverse formulations are available like timolol, 0.1% gel, 0.25% gel forming lotion, 0.5% gel forming lotion, and 0.5% gel. And finally, 0.5% eye drops. This is something that we use. The other pearl of practice very quickly is on using intralesional measles, mumps, and rubella vaccine, which is MMR immunotherapy, in molluscum contagiosum, which is very difficult to treat in a small child. There is a lot of crying. It's painful. So consider the role of cell-mediated immunity in the pathogenesis of molluscum contagiosum. The advantages are the relative ease of the procedure, time and cost effectiveness, wide availability of MMR vaccine, and minimal pain, which is important, and adverse effects associated with intralesional MMR. So this is a promising modality. These are certain anecdotal reports. And remember that assess the existing immunity to MRR vaccine by first giving intradermal injection of 0.1 ml MMR vaccine into the volar aspect of the forearm. Positive reaction is defined as erythema and induration of at least 5 millimeter in diameter in 48 to 72 hours. Intralesional MMR using insulin syringe into 2 to 3 lesions. It should be done, and maximum can be given of 0.5 ml of the vaccine in one sitting, and volume injection in each lesion range from 0.1 to 0.3 ml. So 3 weekly intervals up to a maximum of 3 injections can be given. And this is 0 week, 3rd week, and 6th week. So these are pictures from the article where multiple molluscum contagiosum papules over the face, very tough to treat. There's goblerization, an improvement seen at 12 vaccine. So this is something to remember and do. Lastly, I come very quickly to biologics in pediatric practice. Remember that etanercept was EMA 2009 approved in children aged 6 years and above. FDA 2016 approved in children 4 years and above for severe chronic plaque psoriasis refractory or intolerant to conventional treatment. Off-label indications are hidradenitis suppurativa, AD, pyoderma gangrenosum, SGS10, Kawasaki disease, and juvenile PRP. Adalimumab, EMA approved 2015 in children 4 years and above for chronic refractory plaque psoriasis, and FDA and European Union approved for moderate to severe hidradenitis suppurativa in patient 12 years and older. This is an incapacitating condition. Infliximab off-label is psoriasis. Anecdotal case reports in AD, 10, and HS. Ustekinumab is FDA and EMA approved in adolescent 12 years and older for the treatment, again, of refractory chronic plaque psoriasis. Few cases in adolescents with recalcitrant AD. Secukinumab, not licensed for use in children, but there are case reports for psoriasis. Omalizumab, we know, is FDA and EMA approved 2014 for treatment of antihistamine resistant CSU or chronic spontaneous urticaria. in children 12 years and older. So there are case series and series demonstrating its efficacy and safety in children. But remember that it is used off-label for treatment of moderate to severe AD, but has not really been found to be that useful. Dupilumab is the first biologic agent approved by FDA for children 6 years and above with moderate to severe AD not responsive to conventional modalities of treatment. So this is around the corner. Apremilast is off-label so far for psoriasis, AD, and lichen planus, but remember this is a much better drug to use during the pandemic and with fewer contraindication. Crisaborole topical PDE inhibitor is FDA approved for AD in children 2 years and older, and we look forward to its introduction in India. Rituximab, reserve it sometimes for severe and refractory pemphigus vulgaris in children and adolescents. There are anecdotal reports. JAK inhibitors, tofacitinib, the evidence is now mounting. Oral or topical, which has to be introduced, but we have the oral one. Ruxolitinib cream, which is soon going to be there, and oral baricitinib in phase 3 of the trials used in atopic dermatitis, also in alopecia areata and universalis with significant regrowth of hair. Last word about biologics and vaccination. The vaccination schedule of children should be considered before administering. Better to finish the vaccination schedule before starting biologics. If there are live vaccines to be given 4 weeks before and inactivated vaccines 2 weeks before starting biologics. Live vaccines generally to be avoided during therapy, but if required, then the biologics should be continued for at least 3 half-lives. Inactivated vaccines are safe to administer concurrently, but response may be pretty inadequate. So there are a lot of advantages, but be careful before starting them. Also, what are the pitfalls? Long-term safety data at the moment is lacking. There's an increased risk of malignancies to be assessed, so children may continue receiving these biologics once started well into adulthood. So I'm little careful before I give systemic drugs like cyclosporin and even biologics, yet they are good in the armamentarium. So before I thank you all for your attention, listening to these pearls and pitfalls, this is my book, latest book, Atopic Dermatitis, Text and Atlas by me and Dr. Anupam Das. And this is available by Knowledge Bridge Publishers. So thank you so much for your patient hearing.
Thank you, ma'am, for your wonderful presentation on pediatric dermatology. Thank you once again. So moving forward, I'd like to invite Farzana Suri ma'am as the next speaker. She is currently affiliated to Farzana Suri Victory Coach. Talking about her, she is a former ad professional for 17 years. She has got more than 6,500 clients across 23 countries. Talking about her, she was born into the family of legendary Urdu poet Mir Anis, and writing is her passion. She has a vision to make a positive impact on 1,000 lives each year, one soul at a time. An interesting fact about her is that she was a former chartered accountant. Today, she'll be presenting on a special topic, that is, victory is in your hand. Over to you, ma'am.
Hi, everyone. I hope everyone can hear me. I'm going to share my screen now. Just let me know whether you're able to catch it. All right. So share sound, optimize video clip. All right. Can you spot my presentation?
Yes, ma'am.
Fantastic. Fantastic. So before we begin, my topic is victory is in your hands. So very quickly, I want to ask each one of you, and one of you can just help me because I may not be able to see my chat. Can you remember your very first victory? can you remember your very first victory? I would love you to use the chat if it's possible. You know, are the messages coming on the chat? Can someone just respond to me?
Sorry, ma'am, we are not able to see the chat box.
Okay, so I presume people are putting up in your a few. So I know which was your first victory. Now you're going to wonder, how is that possible? Well, you know, you were exactly the people, including me, who beat not one, not two, not three, but over 200 million to come into this world. Okay, so I'm talking about when you were a tiny sperm and you beat 200 million. You know, you raced against. You didn't even look at competition. You were just, you know, focused on the fact that you want to get out there and come into this world. So, ladies and gentlemen, that is your very first victory. That is your very first victory. And today what I'm going to do is I'm going to just share with you 5 steps to victory, which is based on my life, my learnings. Some of it will resonate with you because, you know, I mean, I'm with a bunch of extremely talented, extremely admirable personalities today. And it is my pleasure and honor to be here. So the first step, if you want to win in life, if you want to really be a champion in life, the first step is welcome discomfort. What is making you uncomfortable right now? Because each one of us, yeah, we're bothered by something right now that is probably not making us feel very great. It could be in our personal lives, it could be in our professional lives, it could be in something that we ourselves are probably, you know, struggling with. So victory begins with discomfort. If you are in the comfort zone, trust me, then you're just existing. But if you want to win, if you want to get there, if you want to achieve something, you've got to be tuned to discomfort. That means you need to welcome it, okay? And when you welcome discomfort, magic happens. Think of 2020. How many of you really hated 2020 in many ways, especially the first few months? I know I just could not adjust to 2020 in the first few months. I mean, I'm a trainer, I'm a coach, and I believe in, you know, meeting out with, meeting people, connecting with them, especially in my training programs, and then just to be stuck on the screen and not being able to see the participants, not being able to interact with them kind of made me feel very, very edgy. But then, that is what victory is all about, isn't it? If you have a winner's mindset, what do? There are 4 things that you do. The first is you've got to reset. You've got to recalibrate. Whatever you've been doing, you've got to see it with a different lens. Yeah. You got to then be ready to accelerate because you can't be where you are if you want to win. You've got to be ready, you know, like the athlete. You see, when they're taking a stance, they kind of readjust themselves. You know, they kind of jump a little bit because they're getting ready to create a change. The third thing is take command over the situation. Take command over the situation, or else the situation will take command over you. And the fourth important thing is you've got to engage. So whatever it is that is coming your way, you have to take it head on and you have got to race. You have got to race and go beyond wherever you are right now. That is the first step towards victory. The second step to victory is we call inner talk. All the time, even right now, you're probably having a conversation with yourself right now. And we all do that. We all do that. And how do you think inner talk, what do you think is the narrative? What do you think is the, is the main subject of our inner talk? The thing that drives our inner talk. It is our experiences, our beliefs, and our values, which we borrow from people. So if I had to ask you another question, imagine that you have just been born into this world, okay? And all of you are in a hospital, in those little cradles around the hospital, right? Do you think any one of you would be different from the other? Would your parents, when they walked in, be able to differentiate and figure out, oh, this is my son and that is my daughter? No way. No way. Every one of you would be the same, same, fingers, same face, 2 eyes, nose, lips, etc., etc. You would be just the same. But something changes. Right there in the hospital, something changes. Someone takes you in their arms, looks at you and says, oh my God, doesn't he look just like his father? Or, oh my God, look at the way she's cooing. She's, it's almost like the song, the way her mother sings. Her mother's a singer, so she sings so well. And that is when our narrative gets changed. We are all born to win, all of us. But the stories that we imbibe from people around us, the experiences that we go through, what people tell us, it could be our caretakers, our parents, our grandparents, our friends, our teachers, whatever they say to us becomes our belief. And that belief drives us to do what we want to do. And victory begins with, how do you talk to yourself? So I'm going to show you a clip. I'll need someone to help me, whether you can hear it, because this is important. Yeah?
Finish on 4 meters 70. This is not a sign that we want to see. I can tell straight away that Angelica is okay. Whether she's going to actually, for the girls, and let her borrow her pole. She's very entitled to. What's going on down there?
And they are essentially an international club. And she's over. Everybody is on their feet.
Finish up.
Yes. All of us are born to win. I just said, look at this lady. Yeah. Very, very important event. I mean, athletes struggle for the entire year, sometimes years together, for that one event where they can prove their skills and their talent, to the world. And imagine at that point, when your tool malfunctions, and what do you think we all would have gone through at that stage, at that point that Angelica went through? We would ask ourselves, oh my God, we're lost. We've lost it. This is it. This is final. Nothing can happen after this. But what you tell yourself at that point, when you are broken, when everyone around you probably thinks you can't make it, that's when you have the power, ladies and gentlemen, you have the power to change your language, to speak to yourself in such a, because at that point in time, you are the only person, you are the only mentor mentoring you, you are the only coach coaching yourself. Nobody is around you to do all of that. And that is when you have a conversation with yourself and you use the language of victory, that you can win. And that's what we saw just now with Angelica. She not only, won, but she won by a huge margin. So the point out here is, when we are down in the dumps, when we feel, hey man, nothing is going to work, we start complaining, we start moaning, we start whining about how bad the world is, how things are not working in our favor. The moment you start talking about what is not happening in your life, you're attracting more of that. But the moment you start thinking and of a conversation which is elevating, you choose words which are elevating. So instead of saying, when a project comes to you or something new comes to you, maybe a situation, a case study comes to you which you feel, I've never done it, ask yourself, what is the opportunity here? Because if it has come to you, it means there is a reason why the universe has sent it to you. Okay? If there's something that you don't know, ask yourself, how can it be done? And sometimes it may make more sense to reach out for support, because trust me, we don't have all the answers. We don't have all the answers. In fact, the best space to be in is in a space where we say, you know what, I want to empty my cup and I just want to learn. Like today, empty your cup and just absorb and just learn. It will affect and matter to at least one person in the lives of the people that you treat. Because to me, I feel, doctors in the dermatology area are like healers. In fact, you are like healers. You're healing not just the outer experience, physicality. You're healing the soul of a person, of a human being. I just saw Dr. Rashmi's presentation just now, and that's what she's done. And all of you in this room. So the point is, every time you feel you're going down, the only way to move up and to elevate yourself is to flip the negative. Every negative that you have, ask yourself, what is What can I say to make it positive? And that is the language of victory. It is invigorating, it's elevating, it is inspiring. And the only person who can inspire you is you. The other thing is, I love this, which is shake your ass. Shake your ass whenever you are upset, angry, feeling like things are not working your way. Yeah. Another thing, apart from changing the way you speak to yourself, using the language of victory, is to shake your ass. So literally, it means get up from wherever you are, take a walk. Do you remember when we were upset or angry or worried about something? What did our parents and grandparents say? They said, you know what? Have a glass of water. Have a glass of water. Why do you think they said have a glass of water? Because it changes the chemical reactions in our body, right? I mean, who am I talking to? You guys know this the best, right? The dopamines, the serotonins, they kick in, and the cortisol kind of takes a back seat. So every time you feel not so great, do something that elevates your soul. Do something that can make a shift. You don't have to respond to anger right away. You don't have to respond to any frustration right away. You can make it happen, because your belief in how you see yourself can take you towards victory. The third tip, be outcome focused. Focus on where do you want to go, and eventually what is it you want to achieve, because that is the most important thing in any goal, in any ambition, in any desire that you have. If you have that in mind, then everything you do on a daily basis to take you towards that goal, whatever be that goal. You may want to have a larger clinic, you may want to have a franchise, you may want to have more doctors working for you. If that is your focus, what are you doing today to get there? Every day, every moment, what are you doing today? So I have a very simple process that I use. Every time I want to achieve a goal, every time I want to win at something, I make that my password. I make that my password of my email. I put that on my screen to remind myself that this is where I'm headed. Because every time when I'm picking up my phone to even make a conversation, I ask myself which conversation that I have with a person. Okay, it could be a client, it could be a colleague, it could be my family member. How am I taking it forward? So be outcome focused, because results count, reasons don't. And the way you do anything is the way you will do everything. And that is how you will also attract the energies around you with the kind of people who work for you. Because if you set the standard, if you set the benchmark, everyone around you will have to follow that standard and the benchmark. The fourth thing is manage stress. I know as doctors, I have not seen anybody, especially in the last 1.5 years. I mean, it's come so much to light, because so many things psychosomatically have affected so many of us. And I think as doctors, as healers, you are no less in receiving all of that comes to you. The best way to manage stress is manage your relationships. Manage your relationships. We forget that we have relationships that we need to take care of, right? And when I say that, I mean, there is a beautiful concept which is called a love language. A love language. Every one of us, we speak in different languages, right? Why do we speak in different languages? And because the language which we speak to our people, it connects each other. It's a communication code. So just like this communication code of English, of Hindi, of Nepali, or whatever you speak, okay, there is a language code even for love and appreciation. Yes. With your patients, with your partners, with the MRs who come into your clinics, there is a love language that we need to use if you want to ensure that you have lesser stress in your life. And the way to do it is what I call, it's called, there are 5 languages of love. The first one is words of affirmation. Words of affirmation. When I say words of affirmation, it means some people are driven by the word thank you or sorry. They don't want gifts from you. If something has not worked out, they want you to come and be open with them and say, hey, you know what? I'm sorry, I messed up. They just want to hear the word sorry. And we forget saying that because we get egoistic. Sometimes we forget to say thank you. All the person wants is a thank you from your lips, or an I love you, or I care about you. We don't say that. But there are some people, they only understand that language. There are some people who understand the language which is called quality time. They just want to spend time with you. That means when we are sitting at a dinner table or when you are talking to your patient, they want eye contact. They want you to actually be invested at that point in time in them. Okay, they want you to spend quality time with them. The third kind of language is receiving gifts. There are many of us, we don't want thank yous. We don't want sorries. We want you to give us the gift and show us that you really are thankful. We want you to just say, instead of saying sorry, we want you to give us a gift and say, hey, you know what? That gift actually is thank. It doesn't matter how expensive that gift is, how small that gift is. The fact that you just gave me that gift meant that you cared for me, and that is my language of love. Yeah. The third language of love is act of service. That means sometimes what happens is, I'm working on a certain project or something, and you just come and you say, hey, you know what, can I help you? I just need you to say the words, can I help you? And that in itself to me is the feeling that, you know what, I'm cared for. People get stressed because somebody's language is affirmation and somebody's language is receiving gifts. Can you imagine how different it is going to be? Yeah, how stressful that relationship is going to be. It could be in your clinics, it could be with your patients, it could be with your family. So if you really want to manage your stress, manage your language of love. And the third one, of course, is physical touch. That means I don't want to thank you, I don't want all of this. I just want you to come and pat my back and say, well done. That's all I want. Don't give me a gift. Don't even say thank you. Just come and pat my back. That to me is valuable. So do you understand the language of love in your relationships? So these are the 5, languages, and this is one of the core of reducing stress in your life. If you understand this, if you know how to manage your relationships, trust me, you know how to create ease in your life. The other thing is manage your time. Very many times I know you get carried away because you're so invested in a patient or you're so invested in a particular process or function that you forget to manage time. But ladies and gentlemen, time is one of the most precious gifts, and you need to manage it for yourself as well. Okay. Second is audit. Audit things that are not working for you. And one of the biggest things that doesn't work for many people is guilt. The moment you sit with guilt, you will overextend yourself. And when you overextend yourself, the only person who's going to be stressed out and you'll start overthinking things, you'll start over-imagining situations. And what do you think this is going to happen? It's only going to make you very stressed. So the second thing is audit this. Third is stay in the moment. Forget the past. You don't have to think of the past. Forget the future. You are here right now in this conference listening to Farzana Suri. Can you just be here? Forget about a patient that you're worried about. Forget about something that is happening around at your home right now. Just zone out and be in the moment. This is the best way. Go zen. Go zen. Yeah. Play. Many of us forget there is something called play. We need to build time, to relax. And when I say play, it's not necessarily playing only with your family and, having a fun time with your family, but it also means fun time with yourself. What are you doing? Ladies and gentlemen, I really want to ask, and I want you to note this down. What are you doing, for your me time? How are you enjoying your company? What are you really doing as Rashmi or Arpana or, Sunil? What are you doing for yourself? Because if you are not doing something for yourself at least once in a week, that means you're only going to fill yourself with that stress. And last but not the least is gratitude. Keep thanking everything. Even something that messes up, say thank you. Even something that's fantastic, say thank you. Thank you is the most powerful mantra in life. And lastly, this is my, I have just a couple of slides more, is leave a legacy. Whatever you do in life, leave your mark. Because that is what we are here in this world for. We are always impacting people. The patients that you are working with, the MRs that come to you, you are impacting their lives. The families that you are with, your family, you're impacting their life. The children, yeah. And the best way to do that is, first of all, build your brand capital. As doctors, I know many of you forget to do that. You're just so carried away in the service that you're doing, you forget to build your brand capital, and that is important and the way to do it is be unique. Whoever you are, whatever is your personality, Be unique, be you. If you are a kind of person who's efficient and your patients love you because you're very methodical, and the way you work on your patients is all about that, then be that. If you are very caring and very humorous, and you like to bring in the fun into it, and that's your nature, be that. Okay, be consistent. Be consistent, because that is what a brand is. If you buy an Apple phone, or you buy say a bottle of water, Himalaya water, I mean, you want it to be consistent every time you buy that, isn't it? Just like that, you are a brand, and your service also needs to be consistent. You cannot afford to be temperamental. You cannot afford to be temperamental when you are dealing with your customers, which is your patients. Yeah, whatever you say, follow through. Whatever you say, follow through. If a brand tells you that my after sales service is good, and when you have a problem and you go back to them, and if they don't serve you that way, do you think you're going to recommend that brand? No. Just like that, you need to follow through with whatever you have set as an expectation with your patients or people who come and deal with you. That's the first thing. The second is always be learning. Don't just learn about your work and what you're doing as doctors. Expand your worldview, expand your vision, and learn something new, learn something different. If you've never, played an instrument, learn to play an instrument. Because what happens is, as experts, we forget that there are many other aspects to our life that make us an expert. So do something different, and always be learning and upgrading and upskilling yourselves. And the last but not the least is network. Network. Even as doctors, you need to network. And if you want to be a powerful networker, you need to be a powerful connector. And what a powerful connector means is very simple. It's a formula called 5-50-100. That means connect with at least 5 people who are part of your inner circle. That makes you a very powerful connector. That means these 5 people you probably connect with on a daily basis, almost on a daily basis. Okay, they must be there with you. Then you have 50 people. These are people who add value to your life. Every time you pick up the phone, you may not meet them often, maybe once a week, but whenever you pick up the phone, they will add value to your life. Then you have 100. 100 basically are people, you may not connect with them a week, maybe a month, but whenever you pick up the phone, they are ready to help you out. You must have this, this set of people, because this is what makes you a power connector. And where do you network? Social media. Ensure that you're on social media. Especially for you, I would say you certainly need to be on something like Instagram, because I just saw the case study with Dr. Rashmi just shared today, and these studies need to be there as well. This needs to be seen by people, because there may be so many out there who probably need you, but they don't know where to find you. So be social. Be connected with people, like you're doing right now. In this conference, you're connecting with each other, you're upgrading yourself, you're learning more about each other. Be a part of social networks. Like I know in Mumbai, in India, we have clubs like the Cigar Club, the Lunch Club, where you just connect with, different people from different industries, and you get to learn more about each other. Then your own parent-teacher associations, your housing societies, your world is your territory. Networking is about connecting people with people, people with ideas, and people with opportunities. So networking is really extremely important. And the way to network is, the reason strengths. Live your brand every time, which means when you go for a networking event, when you connect with people, say at your PTA or or maybe your housing society or your colony, prepare your 60 seconds elevator pitch. How will you introduce yourself? When you're introduced to someone, what are the first words that come into your mouth? What do you say? 60 seconds, because that is all that is needed to get you out here. Okay? Treat people the way you'd like to be treated. If you want to be treated well, treat them well as well. Ask questions. Don't just talk about yourself. Ask questions, learn about other people. We love people who ask us about ourselves, right? Yeah? So do the same with the others. And be a person of value. POV is basically a person of value. That means walk into situations with the intent that I'm going to give, whether it's knowledge, whether it's service, whether it's just, adding energy, positive energy to somebody's life. Add something, give something. That's how you become a brand. Yeah. Follow up and connect. So if you meet people at events and whatever, don't just leave it out there. And don't go to an event thinking, oh, I'm going to meet like 10 people or 20 people. No, you can't. Even if it's 1,000, a room filled of 1,000 people, you can't meet 1,000 people. So go with the objective. I'm going to meet 2 people, but they're going to be really amazing people. And I'm going to build that relationship. Yeah. Follow up and connect. And lastly, I mean, I know I shouldn't be saying this to you, but you need to be active listeners. Listen to what people say, because sometimes what they say is not in the words, it's in the space between the words. And that is what makes you an awesome brand. So victory is within you. Welcome discomfort. Look at your belief. Be outcome focused. Manage your stress, and leave a legacy. I just want to ask you, what resonated with you? What is from all of this, what is that one thing, according to you, you'd like to take back? You'd like to take back, because I don't expect you to know everything. Just one thing that you feel, hey, you know what Farzana said, this one thing I'm going to apply. Because I can be here and there'll be so many people coming here and talking to you. And you may listen and you may be great listeners also. But if you don't follow through, if you don't take that one nugget and act it in your life, yeah? Because, every learning that you take back is like a butterfly effect. It's a butterfly effect. You may change one person's life, and that one person will change maybe 5 people's life, and those 5 people will change maybe 10 people's lives, and the world can change thanks to you. So ladies and gentlemen, thank you very much. I hope this was useful and interesting. It's been an honor to be here. Thank you very much. Thank you.
Like you have mentioned earlier about thanking everyone, I'd like to express a big thank you for inspiring all of us through your presentation, ma'am. We are very pleased to have your participation in this program. Thank you, ma'am.
Thank you very much. God bless. Have a fantastic conference. Bye-bye.
Now moving on with the program, the next session is the free paper session. And for this, I'd like to invite our next speaker, Dr. Neeraj Parazuli. Dr. Neeraj will be presenting on cutaneous leishmaniasis like lupus vulgaris over the face among young male from a remote hilly district of Nepal, a case series. He is currently affiliated at Department of Dermatology and Venerology at National Academy of Medical Sciences, Bir Hospital. He is designated as an assistant professor at NANS. He is a member of Nepal Medical Council, Nepal Medical Association, European Academy of Dermatology and Venerology, Royal Society of Tropical Medicine and Hygiene, Epidermolysis bullosa Clinical Network, WHO Collaborative Global Network for Rare Disease. He has got more than 20 journals published in national journals and more than 10 in international journals. Now I'd like Dr. Neeraj to take over.
Thank you so much for the introduction. I would like to thank the SODVELONCON 2021 for having me as a presenter. It was a very exciting and inspiring lecture by Dr. Suri just before me. So the proper dermatologist lecture might be not so interesting. However, this has been the topic for the day. It's all about the neglected tropical diseases. So my topic is about cutaneous leishmaniasis like lupus vulgaris that presented in young males from the same location in Nepal. The cases outlined are the 3 different cases, all young males from the same location, that was the Calicut district of the country, presented with multiple facial lesions, and morphology was confusing to that of the cutaneous leishmaniasis. However, with multiple laboratory testings and even PCRs done, we couldn't reach to a diagnosis of cutaneous leishmaniasis, and we had resort to a treatment trial. So this case series actually goes along with the theme of the conference that we have challenges in neglected tropical diseases. So with any disease diagnosis, yes.
So can you share your screen with us?
Start sharing the screen. Just give me a sec. Can you see it now?
Yes, sir.
Okay.
Thank you, sir.
Is it okay?
Yes, sir.
Okay, great. So with any disease diagnosis, what we do is we get the clinical features as well as history, and we reach a differential diagnosis. To reach to a proper diagnosis, we do laboratory testing. At times, we will not be able to reach to a diagnosis proper. In that condition, what we do is we go for a therapeutic trial, and the outcome is going to be disease cure. Let's go to the case proper. This is a case that presented to me from Calicut, a young male with an ulcerated plaque over his nose that gradually increased over the period of around 8 to 10 months. For the last 2 months, he noticed another plaque that was in his lower lip. There was no history of fever, weight loss, or any such lesion in his family members, nor there was history suggestive of tuberculosis in him or his family members. Another case from the same locality, a nearby district, Basura, came to me with a history of 6 months of plaque, an atrophic plaque present over the right maxillary region that was still gradually increasing size during this period. Another, same person had an ulcerated plaque over his left cheek. The third case that came to me, as soon as he entered an OPD, I thought it was a case of cutaneous leishmaniasis. A patient had a plaque, a crusted plaque in his right cheek that was present for around 6 to 8 months, and at the same time, he had an indurated, ill-defined plaque at his right ear lobule that was also present for the similar duration of the time. All of these patients didn't have any personal or family history of tuberculosis or weight loss or any travel to the leishmaniasis endemic region. So the investigation we started off was in the line of either tuberculosis, that's lupus vulgaris, or cutaneous leishmaniasis. We did a skin smear for LD bodies to look for the LD bodies, and it was negative. At the same time, we also did for an AFE, which also came out to be negative. So we jumped into a biopsy where we saw multiple granulomas. Most of them were epithelial type of granulomas, along with few plasma cells as well as multiple giant cells. And the diagnosis was given as a lupus vulgaris by the pathologist, despite repeated discussion that clinically it might be a cutaneous leishmaniasis. So as a diagnosis, a biopsy was suggestive more of lupus vulgaris. We decided to go for a PCR testing. So we did a conventional PCR for the Mycobacterium tuberculosis. And at the same time, we did a nested PCR protocol for the Leishmaniasis species, and both of them came out to be negative. If you see in the picture, you can see the ladder, that's the base pair size, and we have a control that's positive at around 700 base pair, and the test we provided was negative. So after this was negative, we did the Montu test that was strongly positive at 25 millimeters of induration. I still did an R39, hoping it might come out to be positive, but still it was negative. A high ESR was noted at 55, and then the chest X-ray done was all within normal limits. For case 2, there was a plaque on the right maxillary region and the atrophic plaque on the left cheek. I did still the same protocol was followed. We did a slit skin smear for AFB, and this time I did a slit skin smear for GEMSA as well as an imprint smear to look for the LD bodies, and both of them were negative. So that right then we did biopsy, and it still showed multiple epithelioid granuloma and with giant cells as well. There was no necrosis, and we couldn't find any LD bodies or the amastigoid forms in the biopsies. Then we did the PCR again, the tissue PCR for Mycobacterium tuberculosis, as well as the tissue PCR we did for Leishmaniasis species, and both of them came out to be negative. RK39 was still negative, but however, there was a positive Montu test, and ESR was raised at 40 millimeters per hour. Case 3, there was a lesion that I suppose was Leishmaniasis at the first go. We did the same protocol with GEMSA stain and AFB stain, but this time I did the imprint smear, the slit smear, as well as an FNA smear, and all of them were negative. The AFE staining was still negative. However, when I look at the biopsy showed multiple well-defined granulomas with caseous necrosis. So thinking it might be a, just a problem with the biopsy, or I thought I would do another biopsy from the earlobe as well. Again, in the earlobe, we found that it was multiple well-defined granulomas with lymphocyte, neutrophil, and few plasma cells. You see the slide in the above as the one from the right cheek, and the slide below is the one from the right ear lobule. So still the PCR was conducted and it was still negative, along with both for leishmaniasis and the Mycobacterium tuberculosis. RK39 was negative. The Monotech was strongly positive at 15 millimeters, and then ESR was raised to 45. So I was confused, and I had a few options, but all of these options were jumbled up at whether I should go for lupus vulgaris or cutaneous leishmaniasis, or I should just wait and watch. But the thing is, the patient had been having the lesion for almost 6 to 8 months, and it was not regressing. So wait and watch should not be an option. And then there was an imminent lockdown in progress. So I thought of giving a trial of medication. So where should I start? Whether it's a lupus vulgaris or a cutaneous leishmaniasis? I was thinking of going into the cutaneous leishmaniasis. So I had an option of either treating the patient with topicals, but the patient were from a remote location, and then the follow-ups would be very, very difficult. And then the efficacy was, it's not very good. And oral antifungals, I didn't know how long should I be using it, but preferably I would have gone for miltefosine. But the thing is, I couldn't procure it unless and until I make assured of the diagnosis of cutaneous leishmaniasis, and the side effects associated with it are severe enough. Or maybe I can just go for a trial of antitubercular treatment. Whatever I start with, the outcome was to get the healing of the lesion and make the patient better of his skin condition. So with a balance hanging between the clinical morphology supporting of cutaneous leishmaniasis, but the rest of the tests supporting for lupus vulgaris, the diagnosis wasn't easy enough. But I decided to start on the patient on a trial of antitubercular treatment. So after 6 months of treatment, the patient with an ulcerated plaque over the nose has a complete healing with scarring. I actually followed up the patient at 2 months after the completion of the intensive phase, and the lesion on the lip has decreased considerably, and the lesion on the nose was regressing in size. The case 3 that I thought was cutaneous leishmaniasis also improved drastically with an atrophic scarring. However, I could not follow up on the patient of the case 2, so I had to do a phone consult. It was only possible, and as I asked the patient replied to me that it was cleared and there was a scar present at the lesional site, at both the lesional site. So there's always a confusion between lupus vulgaris and cutaneous leishmaniasis, though the etiology is totally different, the clinical morphology are similar, and the patient's immunity is both have a moderate to high, good immunity. Histopathology is very confusing. If you see an organism, either an AFB, the acid-fast bacilli, or the masticoid forms, it's very easy to clinch a diagnosis. However, at times it's very difficult, and the tubercular granulomas are more in favor of lupus vulgaris, whereas the caseous necrosis still favors lupus vulgaris. But there is an overlap of the biopsy in both of these diseases. PCR is very sensitive when it comes to CL, leishmaniasis, and we all know with the lupus that in the multibacillary form, we'll have a positive PCR, whereas in the postbacillary, it might be negative. RK39 is not very useful in cases of cutaneous leishmaniasis, but reports have shown that in endemic regions like our country, there might be a positivity of 20%. And treatment, it differs in both of this. So to conclude my case series, at times it's very to find a diagnosis, granulomatous condition, skin condition. And then picture might be confusing. We may not be able to get to a conclusive laboratory testing. Trials of certain drugs may not be appropriate. And then we always think, if I should have done something more to it. But at the end of the day, what counts most is the outcome we get from the patient. That is the healing off the lesion, or at times making patient better off his condition. I would like to thank my department, Professor Krishna and his team from Central University, Department of Biotechnology, for helping me do the PCR reporting, and Dr. Subhash Baral, our dermatopathologist, who helps me out with the difficult cases when it comes to the diagnostic part. So that's all for my presentation. Thank you all for listening. If you have any queries, I'll be more than happy to answer you all.
Thank you, Dr. Neeraj, for sharing your paper with us. I'd like to express a sincere appreciation for your presentation. Thanks a lot. So moving forward with next free paper, I'd like to invite our next speaker, Dr. Mohan Busad. He'll be presenting on efficacy and safety of bimatoprost versus clobetasol propionate in scalp alopecia areata, a prospective hospital-based study. Talking about Dr. Mohan, he's currently affiliated to Gan Regional Hospital, Maldives, where he's working as a consultant dermatologist and venereologist. He has got 2 journals published in National Journal and 4 in International Journal. So now the screen is over to you.
Thank you so much. Let me share my screen first. There is some technical issue here. So when I go to share a screen, can someone help me? So new share, right? And then from there, go to desktop, right?
Sir, we are trying to handle it from here.
Okay.
Dr. Mohan?
Yes, sir.
Please, what you can do is you can just go to your slide and just go to your PowerPoint presentation. Where's your PowerPoint presentation? You're already on screen share. Yes. Now just click it. Okay?
Yep.
And now just maximize it. That's it. Kindly continue.
So it's seen now?
Yes, sir, we can see your screen.
Okay, thank you so much. Okay, good evening from Maldives. I'm going to present about the efficacy and safety of bimatoprost versus clobetasol in the scalp alopecia areata. Prostaglandin analog bimatoprost is a relatively new molecule in dermatology. Next. I'm trying to do next, but it is not. Okay, click. Okay. Starting my presentation, I would like to declare that I have no any conflict of interest in this study. So alopecia areata is a common chronic inflammatory. Sorry?
Your voice is not properly audible.
Really?
Can you speak a bit louder?
Okay, sure. So alopecia areata, now it's okay?
Yes, sir.
Okay, thank you. Sorry for the technical issue. So alopecia areata is a common chronic inflammatory disease that causes non-scarring hair loss. The severity ranges from small patches of hair loss where the prognosis is good to complete alopecia where the prognosis is poor. Talking about the incidence and prevalence, it accounts for around 25% of all alopecia OPD cases in the United States, 2% of new patient attending dermatology clinic in UK and USA, 8% in Singapore, and 0.57% in Mexico. In India, it is around 0.7%. In Nepal, in a study done in Western Nepal by Paudel et al., the incidence was found to be 2.2% in Navalparasi, 0.5% in Kapilvastu, and 1.8% in Rupandehi. In a study done in another tertiary hospital in Nepal, the incidence was around 1.9% of pediatric patients. Alopecia areata can be classified on various ways based on the extent, based on the pattern, that there are new variants, unusual patterns, and based on associated conditions. The treatment can be categorized as first line, second line, and third line agent. First line agent being potent topical corticosteroids and intralesional corticosteroids and contact immunotherapy. Second line agents being systemic corticosteroids, prostaglandin analogs, anthraline derivatives, and others. And the third line agents include JAK inhibitors and systemic immunosuppressant agents like cyclosporine, methotrexate, sulfasalazine, and azathioprine. As we all know, the mechanism of action of steroid in alopecia areata is by suppressing the T-cell mediated immune attack in the hair follicle. But the mechanism of bimatoprost is very much different than that. So what it does, it acts on the hair cycle, it prolongs the anagen phase, it stimulates transition of hair follicle from telogen to anagen. It also increases the hair bulb diameter and stimulates melanogenesis, thus leading to more thicker and darker hair. So when we did the literature review, we found that the super potent and potent steroid were found to be significantly better in causing significant higher hair regrowth in different studies compared to placebo. But in bimatoprost, the study was very much abundant in scalp alopecia areata, but whatever the studies were there, it was found to be significantly higher regrowth in bimatoprost group compared to placebo. And one interesting finding in the study done by Jahir et al. Was there was incidence of less side effect, there was faster regrowth of the hair and earlier response in bimatoprost group. So because of this lack of evidence and lack of abundant studies, we initiated a study in our department. The general objective of this study was to compare the efficacy and safety of topical bimatoprost versus clobetasol. And our specific objective were to compare the hair regrowth between the two groups, compare side effect, onset of initial response, and nature of terminal hair between the two groups. We did a prospective comparative study for a duration of 1 year in a PMC teaching hospital with purposive sampling. And with this PASS software, we calculated the sample size to be 50, and we divided those candidates into two groups, Group A bimatoprost and Group B clobetasol group. All patients who attended our OPD with the following inclusion criteria were included in the study with SALT score less than 25%, stationary or progressive course, and following patients were excluded. That include patients less than 13 years, patients with extensive hair loss, that included alopecia totalis and universalis, patients who had received other systemic steroid or prostaglandin analog within a certain time frame, patients who reported spontaneous hair regrowth, patients with associated autoimmune conditions, patients who had alopecia areata and other areas in the scalp, and pregnancy and lactating, and all these were excluded from our study. Data was collected using a pre-designed proforma, and ethical clearance was taken from IRB of KMC. Statistical analysis we did for the categorical data, we used the chi-square test. For two-group comparison, we used independent sample t-test, and within the group, we compared using pair t-test. We also used ANOVA for the hair regrowth and SALT score at 4, 8, and 12 weeks, respectively, and data was analyzed in SPSS version 20. So all patients meeting this inclusion criteria were done a baseline hair evaluation using a SALT score, where the allopatic patch size was, length into breadth was multiplied, and it was further multiplied by the percentage of hair loss in that area to get the SALT score. And these are the baseline picture taken in 4 different views, maintaining the uniform resolution and light using a standard camera. And the SALT score was calculated at 4, 8, and 12 weeks using this formula. Hair regrowth was assessed at 4, 8, and 12 weeks, objectively by measuring SALT score and hair regrowth percentage, and subjectively by a registered dermatologist by comparing serial photographs of the patient with their baseline one, and any growth greater than 25% was considered to be a significant growth. So we calculated the hair regrowth rate based on this formula, and it was categorized into 6 different categories. A0 meaning no change or further loss, to A5 meaning 100% regrowth. So we also recorded the various side effects. We also recorded the nature of the regrown hair, the color of the regrown hair, and we also calculated the onset of initial response in weeks in both the groups. So what we found in our result is that the 2 groups are comparable in all the baseline attributes, the age, sex, duration, mean size of the lesion, number of patients with single patch, baseline SALT score, family history, past history, were all comparable in 2 groups, we suggested by the p-value of greater than 0.05. There was slightly high male preponderance in our study with a ratio of 1.17:1. The results was seen in a study done by Sarma et al., whereas different results were seen in a study done by Lundin et al. And Safavi et al. The main reason for the male preponderance might be because in our study, male have more health-seeking behavior. They have shorter hair, so they notice the loss of hair earlier, and they frequently visit to the barber, so they might have noticed it earlier. So that is our hypothesis. In the age distribution, most of the patients were in the age group of 21 to 30 years in both the groups, followed by 31 to 40 years, which was consistent with the other study done by years. Similar results were seen in a study done by Choi et al. And Tan et al. Most of the lesions were of the duration of less than 1 month, followed by 1 to 6 months in both the groups. The mean duration of lesion was 18.67 weeks in our study, the maximum being 5 years and minimum being 2 days. And less than 6 month duration was seen in 84% of our patients, which is comparable to other studies. Most of the patient had the lesion in the frontoparietal area in both the groups. Family history was seen in 4% of the patient in bimatoprost group and 12% in clobetasol group, which was not statistically significant. Overall, family history positivity was seen in 8%, which is comparable to a study done by Gunzman and et al., but it was seen higher in a study done by L. Asmavi et al. Prior history, we also recorded the past history of alopecia areata in both the groups. So bimatoprost group, there was 40% past history of having similar lesion, whereas in clobetasol group, there was 24%, but it was not statistically significant. So in other studies, recurrence past history as high as up to 100% was also seen. So we also asked for the various past treatment modalities that the patient used. So although 72% of the patient did not use any other past treatment modalities, 28% used different past treatment modalities, which include intralesional triamcinolone, followed by homemade therapies, followed by topical steroid. The mean SALT score reduction at baseline at 12 weeks are higher in the clobetasol group than in the bimatoprost group, but this was not statistically significant. Also, the hair regrowth was seen more in the clobetasol group, that is cosmetically significant hair regrowth, meaning greater than 25%. That is 80% was seen in clobetasol group, and bimatoprost group 72%, but it was not statistically significant. If we see in this graph, we can see that in the initial days, there was high regrowth was high in the bimatoprost group, and later the clobetasol group picked up, which suggests that the onset of initial response was higher in bimatoprost group than in the clobetasol group. So these are the 3 different studies similar to ours that have used this prostaglandin analog and compared with either placebo or the topical steroids. So the sample size in this study, in these different studies, like in ours, in our study, there was significant, non-significant higher reduction of SALT score in clobetasol group than in the bimatoprost group. Yeah.
So due to some time constraint, can you kindly wind up your presentation?
Okay, thank you. Similarly here, clobetasol group is non-significantly higher in clobetasol group than in bimatoprost group, but in the study done by Zahir et al., it was seen statistically significant higher regrowth in this bimatoprost group. The reason could be the Zahir et al. Have used mometasone once daily, less potent steroid. Ours, we had used high potent steroid like clobetasol, and the concentration of bimatoprost used in our study was 0.01% due to unavailability, whereas in the Zahir et al. It was 0.03%. The picture showing the complete hair regrowth in clobetasol group. This is in bimatoprost group. This is partial response in clobetasol. This is partial response in bimatoprost. Also, the pigmented hair we're seeing more in the bimatoprost group, which was statistically significant. And various side effects were also encountered. The most common one being erythema, pruritus, followed by pruritus and folliculitis. Most common one being pruritus, followed by erythema and folliculitis. These were all statistically significant higher side effect in clobetasol group than in the bimatoprost group. These are the different side effects that were seen. So I'd like to conclude by saying that bimatoprost has comparable efficacy to clobetasol with an added advantage of lesser side effect, more rapid response, and growth of more pigmented hair. but it always comes with an added cost. A few limitations I would like to declare are there was lack of control group, there was lack of follow-up after 3 months to see the relapse and recurrence, and the strength of the imidacloprid use was lower in our study. So I'd like to thank the two pharmaceutical companies for providing the drug for this study. And these are my references. Thank you so much for your kind attention.
It was a very well presented paper, sir. Thank you for your effort. Now moving forward, I'd like to welcome our next speaker, Dr. Abdul Latif. He'll be presenting on psychodermatology approach in day-to-day dermatology practice, need of hour. Dr. Abdul is affiliated with Department of Dermatology and Venerology at Government Medical College, Calicut, Kerala, India. He is the professor and in charge at Division of Psychodermatology. He has got numerous national and international publications in his name. He is also the president of Psychodermatology Association of India, fellow of International Medical Sciences Academy, member of European Society of Dermatology and Psychiatry. Now I'd like to hand over the screen to you, sir.
Good evening to you all. Hope I'm audible.
Yes, sir.
Yeah. So at the outset, let me congratulate the organizers for inviting me for this program. Today, I would like to brief about the psychodermatology approach in day-to-day dermatology practice. Psychodermatology is a very important but a neglected area in our day-to-day dermatology practice. So there is a saying in Bhagavad Gita, this man is made by his beliefs, as he believes so he is. And Prophet Muhammad mentioned there is a part in our body, if it is healthy, the whole body is healthy. If it is sick, the whole body is sick, that is mind. Dermatology practice. Here, the skin and brain both originate from ectoderm, so disease of skin can affect the mind and vice versa. And skin is the largest organ of our body and an organ of emotional expression too. And the psychiatric morbidity in OP patients ranges from 30 to 40%, and in IP it is up to 70%. So stress can induce or exacerbate many of the dermatological conditions. We know skin is a part of neuroimmunocutaneous endocrine system. And the stressors activate two major pathways. One is hypothalamo-pituitary adrenal axis, and the other one sympathetic nervous system. And skin has a rich innervation, and neurohumoral secretions are there from the skin. So stress has a significant role in the pathogenesis and prognosis of many skin diseases. So all cases has to be considered as psychodermatological cases if response to our routine therapy is less and obvious psychological manifestations are present. So psychodermatology, it addresses skin diseases in which psychogenic causes, consequences or concomitant circumstances have an essential and therapeutically important influence. So it encompasses disorders providing the boundary between psychiatry and dermatology. So we had conducted a study in India where among dermatologists, their comfort to diagnose and manage psychodermatological cases, that was around 13.3%. And the depression literacy also we assessed in a study. That was a little bit high, but they were not able to manage these cases. So I was conducting a psychodermatology clinic for the last 13 years, and on an average, 600 patients attending yearly. So the common conditions attending the OPD are prurigo nodularis, psoriasis, lichen simplex chronicus, and all these common conditions are attending regularly in our clinic. I'm not going to read these various conditions. So these are the primary dermatological cases. And the primary psychiatric cases like psychogenic pruritus, delusional parasitosis, skin picking syndrome, BDD, body dysmorphic disorder, venereophobia, delusion of body odor, then factitious dermatitis, mucocutaneous dysesthesia, and all. And the overall psychiatric morbidity was 71%. And the common psychiatric comorbidity we encountered is dysthymia, stress of the disease, adjustment disorder, social withdrawal, depression, and anxiety. Then also OCD, delusional disorder, substance abuse, and DDD, panic disorders, and other. So in general, these are the psychological responses secondary to skin diseases. So the classification of psychocutaneous disease, there is the primary psychogenic dermatosis, where a psychiatric disease is there that will lead to a skin disease. That is very, very uncommon. Then second group is a secondary emotional disorders and comorbidities, where a skin disease will be there that will lead to psychiatric disorder. That's common. And the more common is multifactorial cutaneous diseases. That is the common conditions like psoriasis, lichen planus, where the skin disease precipitated by stress, and the mucocutaneous pain syndrome. So in such cases, a biopsychosocial approach is needed. So we have to find out what is the medical problem, and we have to find out what is the psychological factors, and we have to identify the social factors leading to the disease. So a biopsychosocial approach is needed in this type of cases. So a detailed history taking is needed. A psychodermatological consultation is a time-consuming one. So good relationship skills, empathy, these are very important in psychodermatology history taking. So psycho-intervention is an essential part of dermatology practice. So where a psychotherapy and pharmacotherapy both are highly useful. So psychotherapy is a general term referring to therapeutic interaction or treatment contracted between a trained professional and a client. So there are so many techniques, or the counseling techniques come under the psychotherapy. So these are the usual psychological techniques we can use in our dermatology practice. So the various counseling techniques we use, one is an educational counseling, supportive counseling, and psychotherapeutic counseling. So psychotherapeutic counseling is used to manage various psychological problems such as anxiety, depression, stigma, and all. So the psychoeducation, that is very, very important in our dermatology practice. These are common conditions we are encountering, like prurigo nodularis, very difficult to manage. So this is younger children, the one common problem is their educational problems, scholastic difficulty. So in adults, there will be so many psychological stressors and psychiatric comorbidities. And we had conducted a study in our department, and almost 40% had psychiatric morbidity, and depression was common, then anxiety and other comorbidities. So the education we have to give in psychodermatology regarding the etiology and the precipitating factors, because they will have their own precipitating factors. Most of the time in dermatology cases in our part, the cause spider is attributed as the spider bite is attributed as the cause for many dermatological conditions. Then the role of stress we should mention to the patient in a palatable way. Then the non-contagious nature, most of the time the skin disease will produce so many problems in the family, in relationships, in the school if the child is going. So the non-contagious nature has to be mentioned. And sometimes they will consider it as very serious problems like malignancy or incurable disease that will increase their stress. So one of the important stress is the disease itself is a great stress to the patient. Then the various treatment options, the consequences, the prognosis, and your success stories can also be explained to the patient. So various methods, one is a cognitive behavior therapy. Here the thought process and the resultant action is modified. It is not always the disease that is stressful, but how do we perceive them that's important. So various methods are there, I'm not going to the details. So one common one is a rational emotive therapy, where an irrational thought is changed into a rational thinking. So rational thinking there will be an adverse event that will lead to the beliefs and that will lead to the consequences. For example, a person failed in the exam is thinking, I'm stupid. I will never be able to pass this course and I will fail. That will lead to depression. But another child is thinking, failed the exam, that's right, but that's unfortunate and I had some headache or some problem that was the reason for my failure, and next time I can get it back. So there won't be no emotional consequences. So similarly in dermatology, a person with vitiligo is thinking I have a white patch. So people think it is contagious and they will hate you. That will lead to depression. But if he's thinking this is like the paint of the wall that has gone, similarly the paint of my skin is gone, there won't be any problem. So that will not produce any emotional consequences. So this is our governor in Kerala state of India having extensive vitiligo, attending various the programs, there is no problem. Then next comes the behavior therapy or behavior modification therapy. We have studied the classical conditioning, but I'm not going to the details. So in skin also there are so many condition response. This child came to me with a generalized burning sensation. So actually she had witnessed a circus at around 7 p.m. And at that time she witnessed a death well scene, and that produced a special type of sensation at that time, a burning or tingling. So every day after this, she gets the same sensation at 7 p.m. daily, and that affects her academics. So that's one kind of condition. And this is a child with henna phobia. She had some smell of henna at that time of the first time, so she hated that. So whenever she see the henna, she will get that feeling, and she was very afraid of that. So that's again the body is getting conditioned. So similarly, scratching in skin that will produce endorphins and enkephalins, that will produce a pleasurable feeling, that will increase the pruritus, that will decrease the threshold. So that cycle is repeated, and then that also getting conditioned. So if there is one stress, we will scratch and enjoy the pressure. So there is a type of condition. So in operant condition is another method where we can change the consequences of this, and we can increase or decrease the behavior. So in conditions like this, trichotillomania, thumb sucking, lip licking, where we can use these various types of methods. So the various behavior therapies we are using, one is systematic desensitization, then guided imagery, habit reversal, and also this is in these two cases I have explained. But I had done a brief graduated exposure to the fear-provoking situations, and that was coupled with relaxation training. That was an in vivo desensitization, and after 1 or 2 sittings, the symptoms completely disappeared even without any medication. So this is very useful in dermatology practice. Then another thing is habit reversal training. Habit reversal is developed by Azrin and Noon in 1977. So here the principle is an old habit can be broken by replacing it with a new, more desirable habit. So habit is a recurrent, often subconscious or automatic pattern of behavior. So itching is a sensation that needs medical management, but scratching is a habit that needs psychological approach. So often we are telling the patient don't scratch, but what to do with the hands? So we should teach them something else. So in psychology, if you want to replace one behavior, we want to stop one behavior, we have to replace it with another behavior. So in conditions like dermatitis para-artifactor syndrome, like skin picking, acne excoriae, all these conditions, cheilitis, onychophagia, here these are all dermatitis para-artifactor syndrome. There is some difficulty in the controlling that impulse to manipulate the skin. In such conditions, habit reversal is very, very useful. So trichotillomania, very common condition. So here we have to teach the patient. One is we should make them aware of their habit. Then we should teach them a competing response. Then we have to motivate them, and we should generalize the training. So in common conditions where the hand is involved, like scratching, nail biting, or thumb sucking, the competing response is one common thing we can do is holding the hands down at the side and making a fist like this. So whenever they have very severe itching, they can do an exercise like this that will help them to prevent scratching. And like the children, sometimes if they are reading the book, will have that sensation to scratch. The previous photographs I have shown, the prurigo on the leg of adolescent, common is scholastic difficulty. So during reading, they can hold a ball like this in their hands, so they can squeeze it if there is any stress coming, then they will scratch their leg. So So these are other things we can use to reduce the stress. Then mental imagery, that's also very useful, and visualization. So imagination is very powerful technique. So here, an exercise in which one is guided through a series of suggestions provided by an instructor or therapist or a counselor to enhance one's imagination for relaxation or restoration. So we can use in these conditions like psoriasis. So where the body image is completely distorted. So here they have an image that completely distorted and they are thinking, my skin will not come to normal. So in these patients after relaxation, if you are asking to visualize the normal skin, they are going to a normal life, then their subconscious mind will take it and they will get a very rapid improvement. And Hansen's disease, I have tried this and venereal phobia. Here, this patient was with severe depression about to commit suicide. So here also the imagery I had given to imagine that all the organisms are killed by the medication. And after this program, this therapy, he was very well and very quick response and recovery from the disease. Then trichotillomania also we can try this imageries, because if we are giving the imagery that all the hair is completely gone, they will not be happy. So we can ask them to imagine the hair is completely regrown after the therapy, and that will produce a positive mood and they will get very quick recovery. So this is very helpful in many dermatological conditions. So the behavior therapies we can use for the so many psychiatric comorbidities. Then breathing exercise, that is also very useful in dermatology. That will help in calming the mind and body, normalization of sleep, decrease anxiety, and that will increase the parasympathetic activity. Then relaxation therapy, that again very useful in dermatology. So that's a skill, has to be learned. So there are so many methods like progressive muscular relaxation, deep muscular relaxation, rapid relaxation. So we have conducted a study in psoriasis patients. So it has shown very good response, almost 50% improvement in the PASI at about 2 months therapy, comparing with case control study we had conducted in our department. And that's very, again, useful in atopic dermatitis, chronic urticaria, and like an amyloidosis, prurigo nodularis. All these conditions we have tried, the skin picking syndrome, and Hansen's with erythema necroticans. So all these conditions that was very useful. Then body dysmorphic disorder, that is also very uncommon but very difficult to manage. Here also we can use that, but here when the cognitive behavior therapy, that's very useful. Then meditation, that's very important. Especially there are different types of meditations. The mindfulness meditation, that's one commonly used in psychiatric management, especially mindfulness-based stress reduction and cognitive therapy. I'm not going to the details of the mindfulness meditation. Here the various steps, I'm just showing the steps. So here what's actually, we are taking the patient to the current situation and they are living in the current situation. And that is the basic principle of mindfulness meditation. Continue to live as prisoners of these various notions we have created in the mind. In such a situation can be described as a mindless life. But raising to awareness from this state of not knowing is called mindfulness meditation. Then group therapy, that's very useful. So here the concept of disease, the emotional problems they are faced in the society and family can be shared. So a problem shared is a problem halved. So you can see this group therapy in vitiligo patients. So in conditions where we cannot give a complete cure, in such conditions it is very useful to give a group therapy, and the doctor can act as a moderator. So there will be very good result in this, because their stress aspect completely will come down and their coping mechanisms will increase and they will be able to live with the disease. That is very important. Then family therapy is also really important, because they will help to share the psychological burden and help to alleviate the anxieties regarding the non-contagious nature and help to adhere to the therapy.
Sir, can you please wind up, sir? Your allotted time is finished.
I'm just showing the slides and stopping it within 30 minutes, 30 seconds. So this is hypnotherapy. That's also very useful. Just showing the slides and going to stop it. So these are all various methods that we can use in practice dermatitis that's very commonly used. Now the pharmacotherapy, many molecules are there, but the common one we are using is mirtazapine, escitalopram, sertraline, then the antipsychotic risperidone, especially in the usual parasitosis. So it is better to be familiar with one or two molecules. So the advantages of psychodermatological approach is a treatment response is rapid, cure rate is high, and patient sufferings minimized and patient satisfaction excellent. And the frequent indications for psychotherapy in dermatology, deterioration of the skin symptoms under emotional stress, excessive manipulation of the skin, and pronounced social anxieties or avoidance behavior, disfiguration syndrome. So referral to psychiatrist, that is important in major psychiatric disorders or person with lack of insight, severe depression or bipolar disorders, not responding to your treatment, you have to refer to psychiatrist. So in conclusion, psych has an important role in the pathogenesis and prognosis of many dermatological conditions. So dermatological treatment is not complete in the management of skin disease. So in case of minor psychiatric morbidity, psychotherapy alone is insufficient. And in case of major psychiatric morbidity, psychotherapy plus psychopharmacotherapy is essential. So the take-home message is, skin is a major organ of emotional expression. Mind and body has to be considered as a single unit instead of mind versus body dualism. Referral to psychiatrist is often not acceptable to the patient. So basic level psychiatric knowledge is essential to the dermatologist. Thank you for the patient listening.
Thank you so much, sir, for your enlightening topic and a very interesting topic. It's a very new topic for most of us, and I hope we collaborate as was discussed with the Nepal Society as well.
Yeah.
And with this, we come to the end of day one of our 16th annual conference. I would like to thank you so much, distinguished speakers, our panelists, our moderators, for such an enlightening and enriching learning experience. I would like to thank all delegates who have been with us in the site, because according to the data received today, we have around 300 active participation listening to us. So it's a very encouraging number for us. So we look forward to having you tomorrow. We start at 8:30 tomorrow morning, and I assure it's going to be as interesting and as interactive sessions. So thank you so much for today. Thank you, my teammates, my organizing committee who've been with me throughout the day, helping us in all possible ways. So thank you so much, and looking forward to welcoming you again day 2 tomorrow of the 16th annual conference of the Society of Dermatology, Venereology and Nephrologists of Nepal. Thank you so much.
अच्छा तो ये स्ट्रीम होता रहेगा नहीं एंड स्ट्रीम तो नहीं दिखा रहा स्टॉप स्ट्रीमिंग का बटन है अच्छा